Hey, how are you?
Good to
Were you doing? I talked to Jill.
I am.
I'm Jenny Pierce.
We're
Nice
right
to
back.
meet you.
Yes,
Well, right, my better.
We're gonna go ahead and get started.
One night left, so no one in there. And the, yeah, that's quite, so we can.
Can you guys hear me or do you want me to turn on the mic?
I can hear you.
Can you hear me? Good. You guys hear me okay on that? Okay, perfect. And can everybody online hear me? If someone can unmute and tell me that you can hear the audio, that would be great.
Oh, we can hear you.
Oh, fabulous. And we can hear you bright and loud, nice and loud on our little owl mic. Y'all, for those of you who aren't in person, there's this little owl mic and it literally looks like an owl. So it's kind of cool. Well, welcome everybody. It feels so good to have some of you in person. I know there's a number of you online, but so great just to have it sun shining out, have you guys here in person. We don't get to do this nearly as often as we used to. Of course, pre-COVID, we have always have our meetings in person. And now we have some virtual and some in person. And thankfully, we're able to kind of tag team with the annual Rural Health Conference, which is tomorrow. I know a number of you are staying for that. So it's just a great opportunity to see you all in person. I do know that we have a number of you online, but for those of you who are in person, I am going to ask you just to do a quick introduction and tell me where you're from, who you are, where you're from, and one positive thing this week that you've encountered. So, Leah, I'm going to start with you.
Hi, everybody. My name is Leah Hughes, and I am the Projects and Communications Coordinator at the Center. Very happy to be with you all here today. And I'm going to say that that's my positive, so that way none of you can use that.
Okay. Hi, I'm Jackie King. I'm with Arch Pro Coding, actually. I'm just here to listen to all of your feedback and input and catch up on what's going on with your rural health clinics in the state of Michigan. And I'm the Vice President of Hospital Education Services, but I do work with FQHC's rural health clinics. Positive thing, it's just beautiful up here. I like the drive. I drove up and it's beautiful.
Hi, I'm Jenny Pierce. I work at Beacon Health System, which specifically in Three Rivers, Michigan. And I would say the one nice thing is I am bringing a manager and a new educator, and she's never been to a conference before. It'll be your first one.
Hey everyone, I'm Tammy Long. I work for Sure Health. I manage clinics there, plus I serve on the board. And Jill and these lovely ladies here. My positive is that I was happy to be here and connect with everybody. Look forward to Sunday next time.
Jamie Harder, and I'm from Sure Health also. I am the clinic paramedic specialist and market support for our clinic staff. The positive is it's finally being signed up. And hopefully there's some.
I like that one. Just
Yeah.
Yeah.
Hi, I'm Jill Hewitt. I'm here with Sabby Jane. And let's see, a positive is to see bring this person.
She paid her to say that.
She paid.
I'm Rowan Vanderdeen. I'm with Sheridan Community Hospital. One positive thing is I think I've mastered my new puppy at potty training.
I am Terry Breck. I work for U of MH Sparrow, University of Michigan Health Sparrow. I do RUC accreditation in the medical education program, and I also sit on the board. Positive thing, it is not snowing.
I'm Laura Green. I work at the Spire Rural Health Systems. I'm in the role there and hold my hand. I'm a program development and health education coordinator now. And one positive thing is I think we get to get our camper out of storage this Saturday with the nice weather. So I think we'll be very excited as we learn this.
My name is Keisha. I work at Northern Plains Health Center in Buckley. A positive thing is that I have my care manager April here with me this week.
Like that.
My name is April. I'm care manager at Northern Pines Health Center. My positive thing, I got to spend a wonderful morning with my 2-year-old, almost 2-year-old son today.
Oh, those are the best.
Hi, my name is Dr. Todd Ingram, and we're from the Upper Peninsula, Michigan, from Bear County Memorial Hospital. And my positive is I get to spend the weekend with my wife and my friend and coworkers, Amy and Tom, so we're gonna have a good time. Oh, we're all choose.
I love it.
My positive, I have to say words. I'm visiting room from your County Memorial, and I'm the clinic supervisor at the RHC hospital. And our positive is we signed a APP this week.
Actually,
Two of them.
That's awesome.
The one was previous, the last week.
I'm Tom Vanessa, Director of Provider Services at BCMH, and I mean, we still have snow on the ground, still seeing tulips come up.
You're feeling a little jealous.
And I'm Amy Vanessa. I am the clinic care manager of BCMH, and the positive is that I played street hockey with my 8-year-old grandson last night. I did pretty good.
It's a positive.
did you win though?
Bunny Lane, we're the director of operations at the Fire Medical Group. Positive, baseball.
It's that time of year.
I'm Stacey Adams. Stacy, I know, right? I was like, wait, I know her. I'm Stacey Adams. You're gonna hear me talk here in a little bit. I used to work with Wendy like 20 years ago. Yeah, we'll say that. I'm a registered dietitian and certified diabetes care and education specialist, and I'm with Novo, so I'm gonna talk to you today about diabetes. The good thing, I am driving to Pittsburgh after this to see my daughter. She lives there, so I'm super excited to get to see her and spend a little date with her tomorrow, so.
That's awesome. Well, thank you, everyone. Most of you know me. For those of you who don't, I'm Jill Osterly. I'm the Director of Provider Solutions at the center. I've been there 7.5 years already, which is just crazy because I used to attend these meetings and found them helpful. So I love doing this work. It's definitely a passion of mine. Again, this is the best part of my job is when I get to connect to all of you. I get to go out to the clinics and do site visits. It's just something that really, it fills my bucket and allows me to do some of the great things that the center allows us to bring to all of you. I am going to ask Leah because we do have a number of people online and I want to make sure I do my best to include them. I did ask them to put their name and organization and a positive thing in the chat. If Leah, can you read through those for us?
Absolutely. So first we have Misty Johnson from Harvard Beach Medical Clinic. And then we have Carrie Dubbs, who's the RN care manager at Sugar Health. And her positive thing is the weather's beautiful outside. Samantha Kretner, apologize if I mispronounce anyone's name. But they are the Ascension Medical Group. They're from the Ascension Medical Group, and their positive is that they were able to solve their particular sticky revenue situation with a positive financial outcome for the organization.
Love that.
Congratulations. Next we have Darcy Nyblack with Sheridan Community Hospital. Their positive thing is they are a U of M girl like Ruer.
She's so funny.
Next is Tasha Tillery, who's quality at Harvard Beach Community Hospital. It's a beautiful day on Lake Huron. From Jamie Shepard, who's the patient and billing manager at Sugar Health. Positive spring is coming. Happy, beautiful day today. Teresa Kane, RN care manager at Sugar. Positive thing is sunshine. We all love the weather, apparently. Christina Noon from Mackenzie Health System is the sun is shining. It's positive. Angie Titus, love the weather, want to go golfing. Crystal Dean, Aspire, Marlette Regional Hospital from care manager, positive, ready to start camping. And Lisa Porter, system director of ambulatory nursing for Munson Healthcare. So. All of the statements.
Well, thank you everybody for being here. And those of you who chose to take your time out of your day to join us online. We have a jam-packed agenda today. I'm really excited about our speakers. As most of you know, we have pivoted a little bit in our normal, our normal agenda. But I would be remiss before we get started not to highlight some of the wonderful people that I work with. Quite honestly, I really rely on the RHC Executive Board to give me direction, to give me a sense of what's happening boots on the ground, and really appreciate the extra time that they spend with me throughout the year. Of course, we meet quarterly, we try to meet monthly and kind of hash through agendas, what's important, what is information that I need to get pushed out to you all. And they really do help with the planning. So of course, Keisha Sexton, our president, we have Wendy Lingworthy, our vice president. In terms of our members at large, we have Laura Green and Ruann Vanderveen, Tammy Wall, and Terry Bruck, and then Laurel Sawyer. She's from the Trinity Health Group. Many of you might recognize that name. She was with us previously, had left Trinity, and now came back. And of course, she wanted to join our group again. So again, just in terms of what we plan to do for today is really going to be more clinically quality focused, as opposed to a lot of the regulation and compliance that we've seen over the years past. I think we've done a really good job about getting you that information. We'll continue to do that in another avenue. But when we met as a board this last fall, we really wanted to kind of shift the focus this year and really talk about some really pressing issues around quality improvement, around operations, finance, social determinants of health, some leadership development. So those are the things that you can expect to have brought into these quarterly meetings over this next year. But for the year, we want to really focus in on diabetes. So you'll hear a lot about diabetes today, from different aspects, from more patient-related and best practices to chronic care management. How can that be tackled from that avenue? And probably most importantly, I shouldn't say most importantly, how can I phrase this? What matters at the end of the day is that we make sure you get paid for it. Because obviously that continues to allow you to have your doors open and get the revenue for the great work that you do. So we've already done February's meeting, we're on to April. We do have another in-person meeting in August. It will be August 7th, it will be here. Would love for you all to put that on your calendars. Again, the board and I will be working on the agenda. So if there's something really specific within that operational kind of vein that you want to see, whether it's a speaker, a particular topic, let us know. I want to make sure that I bring that in and make it available for you. That's what these meetings are for, is really what's meaningful to you and how you can operate your clinics. And then last but not least, November 13th. And you know, at that time, we don't want to think about that because that's when the skies turn gray and the weather turns cold and we're in springtime. So with that vein around diabetes, we did set some goals for 2025, and that's really to be able to create this RHC network that is focusing on the diabetes care. We know it's one of the biggest challenges in Michigan that we have in terms of chronic illnesses. We want to be able to standardize some of that care, provide some of those tools and information that you can use in your clinics, that you can take to your providers, that you can take to your support staff and your team-based care. Then of course, if possible, if we can secure additional funding to do additional projects, we want to make sure that we're able to do that throughout the year. It's April, we're a quarter of the way through, and looking forward to do more great work. When we talk about the focus of diabetes, I did kind of a quick survey of a number of you and the areas that you all focus on, and please let me know if it's different for one of you. Of course, your hemoglobin A1C, your diabetic foot exam, your eye exam, hypertension control in your diabetic patients, your statin therapy, your kidney health evaluation. We had a great collaborative over this last year that really focused on kidney health and screening for chronic kidney disease, which had some great impacts. We have two of you in the room that participated in that, and you both saw some really awesome improvement in terms of your screening, and also found some of those patients who had not been diagnosed yet. And then of course, medication adherence. So we know those are all priorities for all of you. Is there anything that we missed on that list when you think about your diabetic population, or gaps in care that you need to close, that we should add to this list? When I look at education and bringing things, or specific interventions that we should add to that list. And anybody online, if you have one, please put it in the chat, or just unmute yourself and interrupt me. Susan?
Annual enrollment exam, Tyson, all the fact is we get a lot of those on there.
That's a great one, especially with our older population, and we know oftentimes those chronic diseases hit them hardest. Awesome. And that will help play into some of the chronic care management. As I eyeball Jill in the corner, gonna give a little bit of a presentation on chronic care management and what are some best practices around that. So we will definitely take that back. Anything else?
How about nutrition?
Nutrition. Absolutely, absolutely. That's a great one. Especially for those clinics that may not have a diabetic educator or nutrition services within your community. You know, what are some of those resources? I know last quarter we did have MDHHS on the line with us, and there's a number of resources. Our goal is to try to build some of that out on our website, so you have one place to go. I know there's lots of resources out there, but if we can kind of gather them all for you and put them on our website, so you have a resource that you're looking for. We'll always link it back to the main resource, but you know, hopefully making it easier for one place to go. Anything else? Anything to check?
Also, emphasis on exercise, weight loss, that ties into control.
Awesome. Very true. Overall wellness. Outside of the medications and outside of tracking the different things that you have to track is giving those patients opportunities for wellness and some of that behavioral health intervention. Awesome. So next steps, and I'll be remiss if I don't ask again. We would love for a handful. Yes, we have one in chat. Oh, CGM. Yes. And I know we talked about opportunities at the last quarterly meeting around CGM. And we are looking for some of that. I don't know if you're touching on that in your presentation,
A
CGM.
little bit about billing,
Okay, perfect.
not really particularly.
Okay. And I'd love to hear as we get closer into some of the clinical conversations as to talk about CGM, how you're leveraging it in your clinics, how your patients are using it, what are some of the barriers or challenges you're having around getting CGM to your patients, those kind of things. So what we'd like to do, and now more than ever, is if you are so inclined, most of you can pull your A1Cs for your patients in terms of a report out of your EHR. We would love to be able to look at this as a project throughout the year for everyone. You'll see a survey link on the screen. We would love for you to be able to click on that link and commit to just providing the A1C data out of your clinic. As we continue to bring interventions and information to you, we would love to see some changes over a year's time. And really, this is what we're asking is, you know, you don't have to engage in a program or a collaborative. Just if you can provide us the data and you can listen to us throughout the meetings for us to be able to give you information that you can try to take back to your clinic and implement. We want to see if there's some changes. When we give you some information or you're looking for particular resource and we get that for you, we want to be able to start to track some changes. As you know, HHS had some massive cuts. If you saw the leaked document that came out of HHS, you know, they are zeroing out the State Office of Rural Health as a proposed. Obviously, that's not going to happen immediately. It's got to go through Congress and so forth. But more than ever, we need to show our value to the Federal Office of Rural Health Policy. And this is just one way we can share that we are getting the resources to our rural clinics. We are getting the resources to our rural critical access hospitals. And we are seeing some changes in the overall chronic disease health here in Michigan and across the nation. But more than ever, the more data that we have that we can share with our Congress people and our Federal Office of Rural Health Policy partners, the better position we are to continue to advocate that that line item in HHS's budget is not zeroed out. So right now, of course, the State Office of Rural Health, our flex dollars are all on the chopping block per se in the proposed budget that was leaked. So just a plea there to be able to help us help you and be able to provide us some of that data. So we kicked this off in February. Again, we'll have quarterly learning sessions each quarter throughout the year. Our mid-year progress review will be in August. Again, when you walk through that survey, it'll ask you from data from last year and then quarterly data from there on. I'm hoping that we can show some trends as we look at this, and we still have time to be able to show some trends. I know you're all working hard in your clinics anyways. And then, of course, that final evaluation in November, where we'll be able to show some outcomes, some things that really worked well within your clinics. We do have a small collaborative of clinics that are participating in a collaborative that we're working on with MDHHS. Specifically, they're looking at the diabetic retinopathy screening and how can we improve that workflow process within clinics. From diving deep into what are the barriers, what are the challenges, what are your relationships with your optometrists and ophthalmologists in your community? Do you have them? And then also on top of that, we're providing echo. We had our first echo this week, where it's through the MSU platform, and we host a physician who is extensively trained in diabetes care. She's internist and then also did additional training in diabetic medicine. And so it was really good. I know, Wendy, a couple of your providers listened in yesterday, which was fantastic. And then we had a couple, our provider from Aspire. I think they had one other provider, but I can't remember who that was. But it was a great Laura was on it. Laura, do you want to say anything about it?
It's good, yeah. I found it very interesting, and it was very collaborative. Like, she stopped and said, she went through a couple scenarios, but what do you think this diabetic would be, or what level would be? And the providers on them were participating.
Yeah.
Yeah, and I think the care manager from our organization.
That's who it was. Okay. Yeah.
But I think was I'm gonna say it from Unising, aren't they on there too?
Yes.
Yeah.
Yes. Bay Care from Unising Health Center was on there. Yes.
Yeah. So it was very interactive. So it wasn't just that they're listening to someone talk the whole time. She wanted them to participate in the conversation.
Yeah, and it's physician led. And again, it's really physician based or provider based, because we did have nurse practitioners and a PA on. But really that collaborative kind of environment for our providers in terms of diving into diabetic training. So if there's a provider that you have in your office that really could use some additional education or some resources this next month, they asked the providers who were on the call to bring up their toughest case that they have with a patient that they've been really challenged with. And so they can use that as a case study and then talk about that patient and work through some of the challenges. So it's a great opportunity. Again, this was funded out of MDHHS, out of some CDC dollars. It allows us to provide the education for free for the providers, and they earn 1 CME hour as well.
And just for reference, the nurse practitioner who is on the call, she's been a nurse practitioner since 2009. She's like, I'm really excited just to see our refresher in diabetes education, because it's changed so much. Seeing how you treat patients and the medications that are available. So,
yeah. I mean, clearly, I'm not a clinician. It was way over my head, but it was really interesting.
Yeah,
like,
when they really started being interactive with people, and I just like kind of think back in like, oh, this is interesting. They're all talking.
I know.
Yeah.
I was a little worried for a minute because it was quiet when they first started, but
Yeah, even on camera, sometimes it's hard to get people to talk and to really collaborate together. But
yeah,
they
it really
did.
was.
Yeah.
So again, if you have a provider in your office that really could use this type of education or would be really interested in it and be helpful, or you have a provider that has a really difficult case that you would love to bring as a case study, email me. I'll get you in touch with Renee, who's kind of leading the project on our end. And then we'll be able to report more. Again, Laura is participating again. She's my golden child because she participates in everything I ask her to.
I don't always understand the material. I just kind of hop on and.
But in terms of retinopathy screening, I'm hoping that we have some golden moments that we'll be able to share with the group as we continue to move that work forward. So with the focus on quality, we did remove some of the regulation and compliance kind of things out of our quarterly meetings. Now, obviously, if we have a hot topic or something that's really needing to be addressed, we'll bring that in at our quarterly meeting. But we've pivoted our practice manager webinar series. It used to be a one-day event where we would bring people in person and do a practice manager workshop. We have transitioned this to a practice manager webinar series. It will start in May next month. I believe the first date is the 18th. We still have the same speakers for the most part. Tressa Sakery from HSA. A couple of other individuals from HSA will also be joining us. Julie Quinn, Renee, and then Mary Beth from HSA. And then we also have Sarah Homan from the National Association of Rural Health Clinics doing a session in March of this next year on everything in terms of policy updates and environment of RHCs. So really excited to have an awesome speaker group. This will be once a month, usually on a Thursday. It'll take an hour. It'll be through our learning management system, which allows that to also be all of the information to be housed on the website as well. So you'll have your slide deck, you'll have some community information in terms of their specific questions. All of that will be housed in one nice, neat little package that they can go back and reference. So if you have someone in your office that could really use this type of in-depth education, this will be a live link in the slide deck, but also there's a QR code that you can use. So, and I think that is all I have. So I will hand it over to Stacy. And Stacy is new to me, but we just met a month ago.
Yeah, about a month ago or so.
And let me get your slide.
Yeah, well, while Jill pulls up my slides and I blind myself here. Yeah, I met Jill just in the last month. I was working with Mary Wozniak from the Kidney Foundation of Michigan, and just kind of happened to meet Jill on another webinar, and so here I am. But thank you so much for having me today. I'm really excited again to be in person and it's spring. I mean, do other states feel the same way? I mean, yeah, everybody's excited for spring, so it's so true. So I'll tell you a little bit more about what I do. So who has heard of Novo Nordisk? I don't know if anybody's,
Everybody.
Yeah, so we're, a pharma company, we kind of, it can be good or bad. But what my position is a cardiometabolic educator. So I've been in this role for about 15 years. I've worked a lot of different places in Michigan. I've had people tell me, you care too much about diabetes, which is true. I come from a long line of people living with diabetes. And so I'm really passionate about it. It breaks my heart when I run into somebody whose A1C is 13 and they're like, oh, I have diabetes. I don't really do anything about it. Yeah, my doctor has me on, no, I've never gone to education. They just don't understand and they're not empowered to live their healthiest life with diabetes. So that's kind of my passion and why I'm here. And I have this very unique job that I am unbranded. So Novo Nordisk understands that, if we want to defeat diabetes, which is our company's goal, it starts with education. Medicine has a part, but also lifestyle. I think, I forget, you're from the Berry County, you said, yeah, it's lifestyle. It's all the other stuff. And so that's what my role at Novo Nordisk is about. I work on a team of about 8 educators. We're spread out across the state. So with everybody being in different parts of Michigan, I can get you in touch with a local person. So we're just going to hit on some real brief things today that are going to align with your collaborative and what you're working on with diabetes.
Have to share screens.
Okay,
Folks at
great.
home can
We'll get
see
that up.
as well.
So what I'm starting with, because the heart of everything that I talk about is based on standards of care. So this is anybody, I guess we'll do the first whole question. How about that? Yes. So the American Diabetes Standards of Care, this is come down from about a 300-page document. If you are techie and you like to have things on your iPad, on your laptop, I'll tell you how you can get these. So first poll question, who's seen these in the last 3 years or so? Yeah.
You're in person, you gotta raise your hand.
Yeah, we're raising hands here. Who's seen the ADA standards of care recently? Yeah, okay, awesome. Attended webinars. Okay, very good. So we will just do a brief overview, but okay, so we're, oh, good. Okay, we got 78%, it looks like, no,
22%, yeah, so all over the board. We'll go over some high level things then. So what I wanted to talk about first was there's an app, it's free. If you go on Apple, the App Store, it's called the ADA Standards of Care is what we're looking for. Do I have to do something? Oh, so it's a free app. You can go on if you want to learn more about the classifications of diabetes. If you want to like go through what's a screening tool that I could use in my practice for identifying patients who are at risk for diabetes. It's all in there. So it's really nice. They have some really pretty printouts and things. So it's a free thing. The document itself is about 300 pages, so it's pretty exhaustive. Hopefully what you're seeing here in a second, after we get through the poll question, are what you're really having to report out. It was that same list of what Jill put up with what we're going to work on this year. It's the retinopathy screening. It is the A1C, all of those standardized metrics or HEDIS measures, if you will. So that's really what dictates what you're doing when it comes down to patient care. The center of the, no, that's okay. I am a Plan B girl here, so I'm gonna hand out, sorry, everybody that's in there.
Online, it's showing up fine.
All right,
It's
so we
just-
got in person and handouts here.
Your share result, your poll is stuck on your.
Yeah,
All
like.
right, well, we're stuck on what we can
Share
do.
results of that video.
So this is the actual little reference card, but this has, I'm gonna just enough. All right. We're frozen here. So what this is just when you open it up, it talks, what are we doing? At the very top, what is most important to somebody living with diabetes is healthy lifestyle. So have we sent the person to diabetes care and education specialist? Now, the predicament that we're in, who has a diabetes educator close to them? Okay, oh, sweet, that's more than I thought. Okay, very exciting. Because we are seeing fewer programs overall, so a lot is falling on your plate as you know, primary care offices and as smaller clinics. So that is at the heart of it, assessing social determinants of health, sending them, referring them out to diabetes care and education. Ooh, we're good, looks good. What do you think, this is, I didn't put it as a poll question, but what do you think the national average is of patients who have diabetes, who actually goes to education? What, oh God, we're like, we're 35%. Okay, we got a 5, I heard 30, 3, okay. We're all over the board. It's about 10 to 12% of patients living with diabetes who actually go through the program. And it takes
completion of the program or even just one visit?
That's even just one visit.
So there's,
Yeah.
there's a whole other thing there.
Yeah, it's a wide scope, but that's about the national average. So there might be good in some places, less good in others.
Yeah.
But it's really, you know, it's a conversation the patient can have with anybody in the office, you know, and really asking, have you had a big change in your therapy? Have you had a transition of care? Were you in the hospital? Are you going on an injectable therapy? So I just always like to talk about that is, these conversations are ongoing throughout the year. Every, you know, whenever the patient's in, have you thought about diabetes education? And we really have to sell it to our patients because they, you know, often think of it as the diabetes police. But those educators will break everything down and it takes a team, right? But it takes all of us doing the same thing again and again to get that patient to goal. So I'm going to go through, that's kind of our HEDIS measures and things. This is just those standards of care. It talks about the ADA focuses in now on 2 major pillars. Number 1 is reducing cardiorenal risk. So what you'll see if you listen to anything or any webinars, I'm not going to go through this verbatim, but we are looking at being in this place where we are in 2025. We have medications that reduce patients' risk of having a heart attack, having a stroke, and having kidney disease progression. So we've come a long way and the ADA is really talking about, we've got to look at diabetes through, I say heart and kidney shaped glasses. and do what we can do when it comes down to those therapies. And then on the secondary pillar is achieving and maintaining weight and glycemic goals. So those are the overarching goals. I won't go through that much, but you can reference that. And for the sake of time, I wanted to talk about what can we do on a daily basis when it comes down to working with our patients living with diabetes. I think we already kind of did this question because Jill had that list up. So you've already, kind of said, what are our goals? What are our biggest challenges and how are we going to use this year to get past those? So what I want to talk about today is really this link on adherence. And as a lot of you are working with the patients, some of you are writing the prescriptions, we're writing the treatment, the ADA says this, I'm doing this, and we're measuring outcomes. But what's vital is that chain of adherence in the middle of it. Is this patient, do they understand the medication? Do they know why they're on 3 diabetes medications? How do we get them to really make those choices every day so that we can have those outcomes? And so that is one of the biggest things we're going to talk about today. So what do you guys hear about from your patients about why they don't take their medications? Anybody you can put in the chat or raise your hand.
Cost.
Okay.
It upsets their stomach.
Upsets their stomach, okay, yeah.
GI issues.
Okay.
Other GI issues.
Yeah, okay. GI issues, cost, okay.
Needle phobia.
Needle phobia, yeah, okay,
I think the GLP-1 had some, it makes them really tired,
okay,
right?
okay, that's, yeah, makes them tired, okay. Do we have anything in the chat?
Yeah, cost, out of pocket costs, too expensive.
Mm-hmm. Yeah, okay, so lots of financials. Well, funny, I have a slide on that. So, right, the number one, if they can't pick it up at the pharmacy, they can't afford it, you're not gonna get an outcome because they're not gonna take it. So, how many of you are tracking, and I think it's somebody's talking about this later this afternoon, but tracking adherence through any of the pharmacy portals? Are you talking about that one? Is anybody? No, okay. I know I've sat with nurses at clinics where they're going on to a separate portal and looking at refill rates on some of the diabetes medications for patients that maybe have a higher A1C. So there's some different opportunities out there. But number one, what can we do in the clinic? Asking the right questions. And this may be your MA, it might be, you, and it might be the care manager, it might be the APP. Can we talk about how your diabetes medications are fitting into your budget? Is there a point in the month where you're having to decide between food, paying the rent, and picking up your medication? Because that's reality for a lot of our patient population. How often do you take less medicine? Do you ever share? I often would see husband and wives sharing their insulin, maybe breaking up pills. So really asking some of those questions. Another one is, who has formulary status checks in their system?
EHR.
Yeah, through EHR. Yeah, sorry. Yeah, okay. And sometimes when you have it, it's not accurate. So that can be an option. There's some other, fingertip formularies, some things like that where you can check, because most of the time your patients aren't going to have what's covered on their plan, or they're not going to know. The one thing, and this, I do a whole hour talk on this, so, but what is that patient's insurance? Are they Medicaid? Are they Medicare? Or are they commercial insurance? Because the financial help is different with all of those. Are you utilizing the extra help program through the Center for Medicare and Medicaid Services? Okay, if they don't qualify for that, can we do drug company assistance? I know our company does up to 400% federal poverty. So it's pretty, ballpark figure, I think it was about $70,000 that a couple could make a year and still get free medicine from our company. So there's always do your research on the different companies. Has anybody heard of the Michigan Collaborative for Type 2 Diabetes? Is anybody a part of that? It's something Blue Cross Blue Shield is doing. Okay, awesome. Have you used their formulary grid?
Yes,
Okay.
I reference it all the time.
Okay, yeah, so this is, if you haven't done it, it doesn't matter if you're part of this, but it is gonna give you some tools at your fingertips to help make the best path of least resistance for financial coverage for patients. The website is the MCT, the number 2D.org. So MCT2D.org, or MIC2D is what one of the care managers I work with calls it. It has so many things that are going to help you out. There's a formulary tool on there. There are a number of different, there's something for finding all the drug company assistance programs. So lots of different resources that are right there. Okay.
If I can interject really quick. April, so when you use that, what is your one favorite tool out of that?
Definitely the formulary.
Okay.
I also like the patient assistant. They give a guide for all the diabetic medications for patient assistance. So you can easily see if a patient qualifies or not.
Yeah, so it has, right, the federal, what qualifies them for the help, yeah.
Nice.
So, yeah, and I really, part of what I love about this job is I get to connect everybody with resources. As much as we try to break down silos in healthcare, we all kind of do our thing and we have our outcomes, everything we need to do, but that's probably my favorite part of my job is getting to share out and really help everybody improve their patient care with it. So another one, I forget to take my medication. I've had patients that just throw all their pills in their pocket in the morning and hope for the best. So how are you remembering to take your medication? How many times a week do you miss taking your medicines? If you have patients that are taking multiple daily injections, that is a prime time for asking the question in the course of a week. How many times do you forget to take your long-acting insulin? Or how many times do you forget to take your short-acting insulin or your rapid-acting? What has helped you to remember to take these in the past? Can I share some suggestions with you? In making it, when you're empathetic and you put that expectation of, you're human, you're going to miss your medication sometimes. That opens the door for such a robust conversation. And it's been interesting just through the course of working in diabetes for, 20 years is sometimes you hear like, do you take this? Do you take that? Or as a patient, if my provider is doing a med reconciliation, are you taking this? Are you taking that? It's a yes, no question. So opening it up with a little empathy, like, hey, you're on 15 different medications. How do you remember to take all of these? Tell me a little bit more about how, the GI side effects that you're having. Have they gone away? Have they gotten better? Do you notice a difference when you take it with a meal? So just asking some of those questions really opens the door. I know it can be hard because we have so many things to go through in our, in that 15-20-minute appointment with a patient, but always remembering that the more that we can get the answer through them, the better that they're going to stick with that change. So, anchoring to, this is pretty standard, but anchoring to brushing your teeth, weekly medications like the injectable therapies. Can you, do it on trash day? That seems to be something that patients do every week. So just asking them, what's something you do every day, every week, about the same day, about the same time? So, all right. Then if we look at depression, that is right, chicken and egg with diabetes. Diabetes requires a lot of time and a lot of just extra mental load. If they're on, they've got to take their blood sugars, multiple times a day. Hopefully they're on CGM, if we talk about that. So that's a little less obtrusive. But then we got to take all these medications. We got to think about eating. We got to think about exercise. There is something called diabetes burnout. Has anybody heard of this? Yeah. Okay. Awesome. Yeah. It happens in type 2 as well. Yeah. It's a lot. We ask patients living with diabetes to do a lot on a daily basis. If we clocked it out, it's about an extra 2 hours a day of just caring for their diabetes. So it's a lot. And so it's something that, again, addressing it in the room and asking those questions. I think we've done a great job in the 20 years that I've been working of now we do depression screenings, and I'm guessing you guys all have done that depression screening. But it's always good to ask about it. Does your, is your diabetes impacted by your mood? That's always, or if you have a patient who they say, yeah, I forget to take my insulin at night. And sometimes depression can be linked to that when they have that hopelessness of like, what's at work? Why am I going to do this? So just asking those questions. Side effects, I know I heard a couple of people say the GI side effects. Metformin, that is like our standard medication with the worst side effects. So are we starting it low and slow? Are they taking it with food or are they taking it on an empty stomach? So identifying what that GI side effect is. Are we using an XR formulation? Have we had hypoglycemia? Is that limiting? That one hypoglycemic episode can limit somebody's medication adherence because that is scary for everybody. So tell me a little bit more about when that happened. Did you need assistance? That also, if you can document hypoglycemia, it will help you get a CGM covered many times. So kind of goes hand in hand. If they are on injectable therapy, having to change those oral medications like the sulfonylurea class, those can cause low blood sugar. Or insulin, you might have to adjust those as well. So asking patients just that, what concerns do you have? If you're adding a new medication, can you tell me a little bit more about what worries you about going on another medication? So again, just asking some open-ended questions. And lastly, if we kind of look at practice processes, just stepping back and being part of this year, you might look at your processes a little bit differently. Can we do a little more team-based care? Most patients, what you see on the screen is patients forget 40 to 80% of what they hear in the exam. So it's, 80%, 60%, that's a lot. And then half of it is misunderstood. Are we giving them tools that they can refer back to when they're at home? Right? Maybe if it's one person, their wife or husband didn't come and they asked them, well, what'd the doctor say? I don't know. So having that printed material is really helpful. And offering plain language, you can do the teach back. Okay, so I'm starting this new medication. Tell me how you would explain it to your mother, your brother, your sister, your husband. And that way you can assess, did they understand it? And then you can clarify. So that's always a good way to work in that. We can look at just the course of an office visit. So what happens using every part of our clinical staff is you're looking at labs, you're looking at blood glucose logs, or maybe you are, maybe you aren't. Is your MA doing a med reconciliation? Are they asking about the cost of medications? Do you have a pharmacist in your community that you can lean on to help you with reminders for refills? I know pharmacies is another whole issue with their closing in all of our rural areas, so that can be tricky. But do you have one that you can lean on? Can we train the front, the receptionist to do some med checks? Just, hey, did you pick this up? We see you're on a new medication. Are we using everybody to improve that adherence piece? Are we referring to diabetes education? And utilizing care management. I know you guys are going to hear about all the chronic care management best practices. So really taking a step back and looking at the flow, the office flow, if you will, can make a big difference as well. Before I go into questions, I wanted to share a couple things. So if you're at home, I think you probably can click on this diabetes education resource library, and it's going to take you to a landing page. So these are all of our education materials that our company, Novo Nordisk, does free of cost. And they're all about 4th grade reading level. So we really do a great job of getting things that everybody can understand and that can be culturally appropriate. And they go through that adult learning need of repetition. They are also available in about 15 different languages. So we don't know if that's something, but last week I had somebody ask for Haitian Creole diabetes materials, and we had them. So there's a drop-down menu that has all of the different resources. So that I brought printed out ones, you can take as many of them as you want. But it really drives home the need for, why am I in here every 3 months? Why are these tests all getting done? Why do I need my eye exam? Why do I need my foot exam? Why do I have to get my cholesterol checked or my blood pressure checked? So those are there. And let's see, I'm gonna not trip myself. I'm just gonna show you a couple of them. So we have checking your blood sugar, knowing your numbers. They're all tier pads. So please, I just set them here, I'll leave them here. You can set up, if you have a website for your clinic, you can set up, this is just a little, you make your own education library of patients can go on. I know not everybody's really tech savvy, but it has a picture of everything that we have, so. And you might find like a lot of, you might have used like our hypoglycemia handout where it's a guy that's like shaking. They've been around since the 80s. I was cleaning my grandma's closet after she passed, and she had like our noble materials. It was pretty funny. So that was neat. We do also have rural areas, we don't always have the greatest access, and so cardiovascular events can be a big issue in rural areas. So we have a whole series on how do you talk to your patient, how do you get your patient to understand lowering their risk for cardiovascular disease. So again, got all different kinds of things. And as I mentioned, I'm in, somebody like me is in the entire state of Michigan. So I have cards. I would encourage you to reach out. I would love to work with you all, and I come and do trainings for MAs. I do like a lot of ATP training. We go through all the ins and outs of diabetes medications, motivational interviewing, just all of those different things. How are you using your EHR to help your workflow and help to make sure that your medication orders are precise and that there's not problems with those. So that's, I know I was trying to get through. We're gonna put your on the chair. Oh, perfect. Oh, thank you so much. Yes. So I'll leave this. Questions, thoughts? Thanks so much for let me talk. Am I good on time? I was trying to.
No, I appreciate
I
it.
have a question or a comment
Oh.
too, you're mentioning, so my mother is diabetic,
Mhm.
and she's even at an assisted living who help her make sure she remembers everything. But there's these payers called Medicare Advantage plans out there
Oh.
that all of a sudden say, we're not gonna pay for that kind of pen of insulin.
Yeah.
You're gonna get this kind of a pen of insulin, which great, they're out there making deals with manufacturers and saving money for our beneficiaries.
Yeah.
But that was a huge problem, because whatever the pen she was on before
Mhm.
is not apples to apples in dosage on the pen she was on after. There are RNs there, but they're not doctors, so they're giving her the 30 units and she's dropping, and she's got a CGM.
Okay.
That's a gap, so a
Mhm.
provider
Mhm.
needs to know, and it said on the Humana thing that they notified the provider,
Okay.
whatever they do to them. But that's a huge thing, because her sugars were dropping and we couldn't figure out why. Well, whatever the two different drug companies, I don't know, I'm not a pharmacist, but the formulation was different. So something for providers to be aware of, it's not the same. I didn't know that, like it's Lantus and I don't know, but it was different, and they
Mhm.
didn't really change the dosage at the provider's office. They just purchased the new pen and started giving her whatever units she was on the other day. I guess that's just something I'm bringing up to providers to be aware of, because
Yeah, that switching is kind
a
of. and it-
manufacturer,
Yeah, and
is-
it happens a lot. We usually would see it with type 1 diabetes, especially with insulins as they go on contract or off. So Humalog, Novolog, they would flip flop. But yeah, they're not always apples to apples. And when a lot of people I've worked with, they're like, well, yeah, if you switch to that one, like it's different in your body. So yeah,
most definitely.
that would be a good time, yeah, for pulling in. If it's assisted living, that's a different situation, but usually they have somebody on, a pharmacist or something that could.
They have nurses, I mean, she sort of has her own apartment, but she was
Yeah.
there just to
Okay.
help, remember meds, you know, really,
Yeah.
that was
Yeah.
because there's 7 of us, none of us live in the same town, and
Yeah,
we weren't confident she was taking her meds properly, so that was the
Right.
start of the whole thing, but.
yeah,
But there is RNs and there's a med nurse that she
Okay.
manages all the meds, but she went by the prescription and I don't know what happened.
yeah.
So anyway, that's,
Yeah, that happens. So all the questioning, the line of questioning, what does it switch to, you know, utilizing pharmacy if we can, but yeah, they should be, you know, this is the thing, is they're a little different in each person, so, yeah.
thank you.
Oh, sorry, yeah. But sometimes, yeah, it's tough, so. Any other questions, anything online from our group here? No?
A comment just to kind of follow up with hers. We had a similar situation with a patient, an elderly gentleman, and his blood sugars, kept going up. So the provider kept increasing his insulin dosage and nothing was changed. And so having all these highs. So we finally had him come in and, you know, let's just go through your process.
Yeah.
He wasn't taking the cap off the needle.
Yeah, yeah, you know, that, I'm so glad that you brought that up, but that happens so often because, you know, we're in the group, like we do these things, you know, insulin, it's, you know, we know that there's 2 caps, but everybody, I think somebody said needle phobia it's a real thing. And so we might have even gone through all the steps of how to give an injection and that patient was scared out of their mind and they're not going to remember anything because they were like, yeah, so going through, if you need checklists, that's something that we also have some checklists that you can go through each step, but that all insulin needles that you put on the pen, they always have 2 caps. So making sure patients know that, yeah. Utilizing videos. So if they are, if it's something that if you've got the iPad type things in your office, can we preload it with a video? So if we are starting an insulin, starting a GLP-1 injectable, can we give them that so they can actually see it? So lots of different tools, but yeah, really, yeah, thank you for bringing that one up. That's insulin is scary and, you know, injectables, I think we've gotten better with the newer injectables with GLPs, but it's still scary, right? It's that in the patient's mind, being on injectable is like this, it's in the ether of like, I failed. And so we have to fight against that mentality and like, well, we can look at this a couple different ways, but we've come a long way, but there's still those issues. So yeah, always feel free to call me and text or email if I can help you guys in any way. So thanks so much. Yeah.
Thank you, Stacy.
All right, thanks.
Really do appreciate that. I am going to pull up the next presentation. And while I do that, I'd like to introduce our next speaker, Jill Hewitt. I just, again, happenstance, I find these great speakers by just happenstance, I think, was able to find her via another colleague. And we've been working together for about 1.5 years. And so Jill is from a company called Savvy Jane. She specializes in chronic care management. I know that's a challenge for many of the clinics because there's just so much to it. And so much to having a really well-run, productive chronic care management program. So Jill is here to give us a few tips and tricks. And then I'll also share some opportunities that we have for the 2025 year post her presentation. Close this one.
Yeah.
You know, we'll just set them up.
All right, since she said she has to leave, before she leaves real quick, I want to tell you, I have a team in Missouri of chronic care managers, which that'll make sense in a second, but we use, yes, we use our companies to come in and do trainings for all of our care coordinators, at least quarterly, and it's been a huge deal for education for our staff. Because our patients don't have a lot of access to diabetic educators. So that's one way we have used, yeah. You guys are, yeah, it's been really, really helpful. What song is that?
Tabasco fan.
Can you, Jill, up there, go to the, what are you went here and went on to the, show results on the internet? Maybe that'll make that guy's question go away.
Oh, shoot.
You know how you did the three dots?
I can't do it from here.
Yeah, it's not
Oh, you
there.
can't? Well, how's it?
Yeah, it's not.
If you can't.
It's with my living.
One way over here,
That's so strange.
there's no, and I can talk, you know. So that's what we did. And then we had the three dots and then show it on the internet. Yeah, or, yeah, that's. It's stuck on the second monitor. And it's thinking that's the second monitor.
Keep talking.
Okay, I can still put it here.
Yes,
Okay.
because the online they can see it.
Okay, perfect.
I guess if I'm lawyer.
Okay, so I'm Jill Hewitt, with Savvy Jane. I am from Springfield, Missouri, and, I actually have two jobs. I'm very lucky because I have two jobs that I absolutely love. My first job is that I work for Ozarks Community Hospital in Springfield, Missouri. We have a critical access hospital in Arkansas, and then we have about 14 rural health clinics, 3 fee-for-service clinics. I also have long-term care and behavioral health. So that journey is what led me to this venture with Savvy Jane. It just happened that we had a really great CCM program going. And we just kept getting a lot of interest and we hosted a lot of different organizations from all different places. And so we just decided to LLC. My partner also works at Ozarks Community Hospital. She's our data analyst. And so we just kind of married the data to the results and we kind of came up with this platform. So we were lucky enough to meet with Jill and she has introduced me to people like Rue and other people. So I love Michigan. I work in Michigan quite a bit. So Jill had emphasized that we wanted to do some outreach and strategies for the diabetes, chronic kidney disease, and hypertension. The rural health clinics, we have the same issues in Missouri, a lot of the same fights we're fighting. We have patients that don't have access to specialists, they lack transportation, they lack education, they're not very compliant, all of that stuff. I think I can't skip the introduction. I mean, I can introduce myself. I kind of did.
If you start, maybe you just give it.
Sorry about the technical difficulties.
Just gotta grip that Zoom platform.
So now I gotta reshare.
So right now, my team, we have about 1,600 patients a month that we manage with Ozarks Community Hospital. I have, I believe, 12 chronic care managers that are throughout the organization. Some of them just do CCM, some of them also work in the clinic. I use a lot of medical assistants. I have a couple of LPNs. That really was a big win for us during COVID because those people were able to answer phones, screen the door, ring patients when we didn't have hardly any staff. So I always hire people typically that have already worked in the clinic and they have just made excellent care managers. They typically are from those communities. They know those patients. So it's worked out really well. Right now, Savvy Jane, we're in Missouri, Illinois, West Virginia, Michigan, and soon to be Montana in June. I'm excited about that. So Savvy Jane, the whole point is that we build CCM programs in-house. We don't want you to use a third-party vendor because we want you to keep all of that stuff in-house to unlock all the potential that chronic care management does. We can build CCM in any platform, in any EMR, and we cater it to you. So every clinic is different. And that's kind of the whole point of being able to cater it. And that's kind of the magic sauce. When I first came to OCH, I think they had 20 patients they were managing. And I believe the word chart was involved and there was just charts stacked. And so we went clinic by clinic, provider by provider, and we just kind of changed the way they thought about chronic care management. We also do 340B data analytics. We want to find ways for organizations to keep all that money in-house. We do a lot of data analytics. If we can see the results, we can fix, we know how to help patients when we can actually see the data. Can I keep rolling through? Oh, there it is right there. Okay. So we are going to hit on creating effective care plans for diabetes, how we can help with CKD, hypertension. We're going to go on the new CCM billing codes for 2025, identify and address missed billing opportunities and how to handle those little sticker copays. I have another word, but I won't say that here for the copays. If anybody has any questions, please, I did the care plans first because we typically have the care plans kind of create the most questions. So if anybody has questions, will you be able to tell me? Yeah. Okay. Creating effective care plans. So we always want to make sure that the care plans always have all of the patient's chronic conditions. We have an issue with this in our current EMR because they want to pull over the problem list and it'll have nausea, vomiting, diagnoses from 3-4 years ago. So we have really been working at using our people and our staff to clean up those problem lists and make sure that the patient is only seeing what their chronic conditions are. Part of that is just the patient being aware. Sometimes they'll come in, they'll say, what is this? I don't have this. So when we send that care plan, I tell the patients, I want you to mark on this, write on this, bring questions. If they have questions and they want to talk about a diagnosis, we make them an appointment with their provider so they can talk about it. We want the treatment. We want to make sure that the treatment aligns with the current guidelines and patient preferences. Anytime we go into a clinic, I always want to see what are your standing orders? What are the orders that you guys have that you use in the clinic? Some of them are PCMH standards. Those are really easy to roll into care model. Those are pretty much what we go by. And then we always want to set SMART goals. We want them to be specific, measurable, achievable, relevant, time-bound goals. Care plans grow over time. And that's where some people really overthink this care plan. Do not overthink this care plan. This is not the full head to toe patient assessment where we have to just figure out the holy grail today. We want to make it simple. And then as that relationship builds with the patient, we will evolve that care plan. The patient also has to understand it. I've had patients bring in care plans and they're like, I don't even know what any of this says. So if they don't understand what it says, they're not going to use it. They're going to throw it away as soon as they get it. So you want to make sure the patient is involved in creating that care plan. The biggest thing when I talk to patients, when I used to talk to patients, and I used to have a team of people, is I want to make sure they know your provider created this care plan. Because if they think I'm just creating it, they may not be as invested if I say, Dr. Smith took time out of their day. We don't get that dramatic, but Dr. Smith created this care plan. He wants to make sure, she wants to make sure that you're reviewing this. If you have any questions, give us a call. Let's see, comprehensive, the monitoring, labs, vitals, meds, all of that fun stuff. We always want to make sure the patient knows what's the expectation in the care plan. How often are they supposed to come in? It can be something as simple as every 3 months, we're going to do a diabetes check. We're going to do an A1C. Every 6 months, it's going to be hypertension, diabetes. Every year, we're going to do the Medicare wellness. I'm glad you brought up the Medicare wellness. We are always chasing the Medicare wellness visit all the time. Some patients don't understand the benefit of the Medicare wellness visit, but we have done a lot more training with staff on Medicare wellness visit. We have brought some RNs in to do more patient-focused visits. They have really liked those. The patients really enjoy talking with the nurses when we do that. They feel like it's more impactful. They're scheduling their appointments for next year. We just rolled that out last year, and that's been a big one. I had one provider that said, well, I just don't see the benefits of the Medicare wellness. And I was like, well, I can see why. Because the visit was pointless. He wasn't doing a lot that was required. We didn't have all that paperwork. And really, the provider should be doing the least amount of the questions. And that's usually some of the hang up in the clinics. They take a lot of time. And if the patient no-shows, you have a block on your schedule. So we have used the CCM team to really go in and kind of knock all of that stuff out ahead of time. So that has made the visits more efficient. The problem list is cleaned up, the health history is updated, social history is updated, and then we can knock those questions out with them before they arrive. The power of a patient-centered care plan. This is my favorite part. These care plans are patient-centered, so the patient has to be at the center of your focus. If we're just putting a bunch of stuff in the care plan and the patient doesn't have any ownership of it, they're less likely to want to follow any directions. We want to make sure that the patient is aware, these are your chronic conditions, these are your medications. The patients will even kind of mark this medication. I'm not taking this medication anymore. And then they bring the care plan in and you're like, great, we didn't know that. The other part is the medication list you can mail out as many times as it needs to be. We always want to make sure the patient has an updated medication list. Anytime the medication changes, we mail out that medication list to them. An effective care plan can reduce hospitalizations and improves your clinical outcomes, and it enhances the care team communication. So you always want to make sure your care plan, every single person in the clinic knows where their care plan is. How many times does the patient call and the front desk will come back and say, they said they're supposed to come back in, but I don't know why. Well, it's right in the care plan. It's also on the patient's care plan, but if they don't have it, that's not very, very helpful. So the care plan should be very detailed on what the expectation is of when the next visits are. The problem list, this is everything that is the CMS guidelines for what is required of the care plan. It'll say it's typically includes, but isn't limited to. I have seen some care plans that are like 20 pages long. Keep it simple, let it grow over time. As you develop another relationship or a more in-depth relationship with the patient, you can add things to it. So it doesn't have to be all of these things, but these are just some of the recommendations. I always want to have the problem list. We always want to have measurable treatment goals, planned interventions, medication management is one. We always want to have an updated medication list. And then the caregiver assessment. If the patient has a caregiver at home, we want to know, does the patient have a caregiver at home? I always say this isn't a HIPAA release when I'm talking to patients. We just want to know if you would be in the hospital and you would need care at home, who would you have? Is it a neighbor? Is it a church friend? Is it a family member? So when the patients are dismissed from the hospital, a lot of times we look at that care plan first off because we want to know, do they have a higher admission rate of being readmitted to the hospital just based on they don't have anybody at home? So these are all things that we can jump on and make sure that we're aware of. Any questions about the care plan so far? You guys have anything that you see gets added into your care plan, or maybe you feel the care plans are too lengthy or not enough? Anything online?
And again, the folks that are online, feel free to put it in the chat or you can come off mute and ask a question.
Yes. Does anybody do care plans upon the first month of enrollment to CCM? I run into that quite a bit. It's a misconception that you have to have a care plan within the first month, and it typically slows people down. You do not have to have a care plan within the first month. If the patient has not been seen at your office ever, it's their first time appointment or 3 years, there's what's called the initiating visit. That is an add-on code to the visit because it's required that the provider also does a care plan during that visit. So it's just an add-on code. A lot of times during the first month, it's really hard to get that care plan knocked out. So I always want to make sure our team knocks it out within 3 months, at least within 3 months. Sometimes we don't have records yet. Sometimes we're still trying to get records from specialists. We have a lot of issues with getting records from specialists. We are not into their system. So we have to get their permission. We have to say, who are all your specialists? Pulmonologists, cardiologists, we want to get those records, providers review. So to be able to put a care plan out the first month is a lot. We're just trying to get a lot of information from the patient and kind of get to know the patient. If you do want to enroll a patient the very first time, then there is that initiating code that you can add on to the new patient visit code. And there's a higher reimbursement for that. But a lot of people are a little bit confused about that because the way it reads on the CMS. So how to highlight diabetes. So how to highlight diabetes is do a diabetic care plan. You can take one diagnosis if you want, or one disease, and you can create a whole entire care plan around that. We like to do it at least 2 or 3 times a year, especially for our diabetic patients. We also do a hospital discharge care plan. So if the patient is admitted to the hospital, we do a care plan after the visit that is solely based on why they were in the hospital. So same with the diabetes. We are going to highlight diabetes, and we're going to build a whole entire care plan around just the diabetic care. I added this in here because this is what I see. We had the providers in some of their notes in the discharge summaries, it would have this real technical stuff and the patients wouldn't quite understand what that meant. You know, they were like, what's my A1C? Reduce the A1C from 8.5 to 7.5 in 3 months, improved medication adherence, dietary changes. So we want to simplify it. Be sure to take your metformin twice per day and avoid late night snacks. As simple as you can keep it to make sure that the patient understands, the better that it's going to be for the patient. The same with the kidney function. So Dr. Smith wants your blood pressure at or below this amount. And then avoid Advil, Motrin, naproxen. Like tell them exactly what it is that you want them to avoid because they do not always understand what some of our terms are.
Someone said I could always do a care plan, with my first visit.
You can if you want to. It typically slows people down, but it is not required unless that's the first time that patient has ever been to the clinic. Especially a new patient, that's a lot going on during that visit. You're trying to get a lot of information gathered. So sometimes that first care plan may not have everything that you want, and that's fine. But that care plan is actually required from the provider during the visit if you actually read that initiating visit code. And I can barely get our providers to do the discharge summary, let alone a whole other care plan. There's a lot. Our EMR is not great. What EMRs are some of you guys have? I know what Rue has. Oh, sorry. Oh, it's even better. Yeah, we have TrueBridge or CPSI. I don't know if anybody's familiar with that. Did you know this? Yeah, it's like we have to get a new hamster every month. Now we have built CCM on that. Now I'm afraid to get away from it because we've got it down, but documentation for providers does take quite a bit. And if we don't help them with it, it becomes very timely. Hypertension, you can mail out diabetic education. That's why I was glad she was here to say that. Not all our patients are going to go to diabetic education. We try, they don't go. So we have actually brought some of them into the clinic. If they're on their particular product, some of the drug reps will come in and train like 5 or 6 people at once. We've done that. We also have them come to our meetings and we do a lot of education with our care managers, which has been really helpful. And then always send that updated medication list. Monitoring follow-up. So set check-ins based on their conditions and very simple. The diabetes, you're going to come in every 3 months if you're uncontrolled, every 6 months if you're controlled. These are all provider guided goals. So this isn't stuff that the care managers are coming up with. These are things that we're getting from the documentation and from the standard of care and from our standing orders with our providers. So we always want to make sure that the patients know within their care plan what the expectation is. Then we use that to follow up and we can do our monthly check-ins with the patient based on that. When I train people, I always tell them, make sure you look at the last office appointment and the last communication. That's the first thing we should do as soon as we touch a patient for the month. We want to see when was the last time the patient was seen and has the patient been calling the clinic and maybe something hasn't, happened. Maybe they weren't notified about their lab results. Maybe I can see that the patient's had issues getting a hold of the nurse to find out about their lab appointment. If the provider provided a new medication, then I know that I want to make sure the patient actually filled that medication. A lot of times you'll call the patient hasn't filled the medication due to cost or prior authorization. Well, it's much better that we know that now than we just wait till the patient's 3-month appointment. The patient's like, oh, I never filled that medication. It was too expensive. So those are all things that we can set within the care plan. And you can always have a reason of why we need to be checking in on the patient, calling the patient. Tailor the education to your patient. So I have a patient that can't read. If he can't read, then all the stuff that we're sending him, communication isn't very impactful. We had a really great handout one year from I think it was from Northo, and it was like a whole entire planner, a meal planner, had all of the pictures of what the food should look like, and they should be the size of your hand. We would bring the patient in and we would talk to him during his appointments, and then we would make copies of that information and send it home with him. He actually started to really improve. Before, he just wouldn't understand because they would give him that discharge summary and he wasn't really able to read it anyway. He couldn't read his medication inserts and he never told anybody about it. The only way we found out was because he wasn't able to fill out some of the Medicare risk assessment paperwork that they gave him in the waiting room. So he just kind of tossed it back to him. So that's something that they may not have known, but with the care management and kind of the constant check-ins, they were able to discover that. Behavioral health. This is a big one. Does everybody have behavioral health in your clinic? This is a new one for us. We finally now have an LCSW or somebody within the clinic. There was a really cool thing that they showed, and they actually showed that patients are more likely to seek care within their rural health clinic than to go off to a specialist because they trust that clinic. So the more services you can offer within that clinic, the more likely those patients are to go there. This has been big with our behavioral health department. Any motivational or strategies, anything that you can think of for your patients. Again, we want to customize everything for your patient. Condition specific, I really like this one. So you can always take the diabetes or whatever condition you want to highlight, and you're going to put, here's the condition, here is the goal, here is the plan, and make it that simple for the patients. I also like to highlight a lot on the care plans so that the patients are very focused to what I want them to focus on. We will go over it in the clinic with the patient. We're not billing for that time if they're seen, but if I can catch them within the clinic that day, then they understand what I'm mailing them when we mail these packets out to them. You could also break this down with every condition if you wanted to, but again, we don't want it to be 26 pages. We want them to focus on just diabetes or just hypertension or just obesity. The role of the care managers. So the care manager, our CEO always says the patient's less likely to fight about the CCM copay if they trust their CCM care manager, which is very, very true. If they have a very good relationship with their care manager, they're less likely to be upset about the copay. But this takes time. You're not just going to get that relationship overnight. So this takes time. Good care managers. The more questions I get about copays, I typically will look into that care manager because I realize they might not be doing a lot of outreach, because my really great care managers, I just don't get a lot of questions or issues with the CCM copay or getting bills for that. Any questions on care plans? Any comments, concerns? We're going to jump into the fun stuff. Coding. How many people are still using GO511? Okay. Okay. Have you guys been getting paid okay on that? Did it drop overall? The reimbursement? What? Yeah, I noticed that too. We were going to stick with the GO511 and try to get the most out of it until June or July 1st. But we noticed that they had dropped the reimbursement about $10. So I wondered. So after July 1st, we will be going back for the RHCs to the 99490 and all of the add-on codes. We've already been doing this in the fee-for-service clinics. My advice on this is I keep it very simple. For my fee-for-service clinics, I don't give them a lot of options of a bunch of different codes to pick. We stick with the 99490, the add-on code, and the 60-minute code. Those are the ones we stick with. It seems to work better that way. So I'm going to be doing the same things with the RHCs. So the 99490 is going to be the first 20 minutes. The 99439 will be the additional. And then we have the 99487, that's the 60-minute code. So yeah, you can definitely keep using the GO511 until July 1st. So we'll jump into the APCM program, but January 1st, they rolled out this program. I was like, great, where are we going with this? Because you just don't know what their plan's going to be.
I think it better tracks utilization, and I really appreciate that they're doing it, honestly.
I know, I'm kind of like, So what I say, I was nervous. I was nervous because of the no time tracking.
Yeah,
Because when I know time track, I'm like, we don't necessarily track time. We do everything by documentation and by templates. So when they document everything within the templates, I know the time's justified. And so I got nervous when they weren't going to do that. I'm like, oh, what are they going to do? You know, what are they going to do now? So the 99490 is the first 20 minutes that we can do. This is directed by a physician or other qualified health professional. I say that because we have other codes that are physician-based time solely. I don't do a lot of those because I like physicians to see per patients. I don't want to spend a whole bunch of extra time doing this. However, I have had to use this in long-term care a little bit for a lot of the stuff that they're doing with that. The 99439 is the add-on code. Again, we go by templates. So if they do more work, they're able to add more time. If you track time, that is fine too. And then, yeah, the 99487. So this is just a little bit more in depth. And if you're sending 60 minutes with a patient, then you probably are going to have the documentation to satisfy that, especially if you're creating a new care plan. Those typically will take a lot of time. If you're having to call for records, run down specialists, see when their next appointment is, that's a good time to use this too. We'll get into the copay part. I don't like to use a lot of add-on codes when I have underinsured patients. So the traditional Medicare only If they get a higher copay, sometimes that makes them want to opt out of the program, and I don't want to lose them in the program. So we don't typically do a lot of add-on codes, unless we have them signed up for patient assistance. We'll talk about that too. So here's the APCM program introduction. There are 13 requirements. You can look up the different requirements. One of them is a robust bi-directional data feed. They actually think our patients are going to take pictures of their rash and send it to the provider, and the provider is going to respond back and send that communication back. We all know that's not really going to happen with this particular patient population, but we just have to make sure that it is in your EMRs, which if you guys have all the better ones other than TrueBridge, you're probably good. I actually had to make sure we did. So there is no time requirement. So I was kind of like, oh, when I was really thinking like, how am I going to track what my team is doing and make sure that we can prove if we do have an audit. If I have an audit, I have sent the GO 511 code, a description of the GO 511 code, their signed enrollment. I learned real quick, we got away from verbals unless it's actually documented within the provider notes. We send their signed consent, we send the care plan, and we send proof that we mailed the care plan to the patient. That is a big one because CMS wants to make sure that we provide that care plan outside of the EMR and outside of the visit. So they want to make sure that we're giving them a copy, we're mailing them a copy. Sometimes I've had to hand it to them in person in the clinic. Even though they have access to this in the portal, I would love to see the actual number of my patients that actually have access to our portal, you know. So the GO 556, I don't think I've ever met a CCM enrolled patient or even a Medicare patient that didn't have any chronic conditions. That's what that code is. There's always something. This is a $15 reimbursement. I think it was one of the other companies that were really, and they were really acting like this was going to generate an extra $10,000 a year. And I was kind of like, oh, I just don't have any patients that don't have any issues. But if you have a Medicare patient that has no obesity, absolutely no issues, here's your code. This is a code you can use. You can always find something. Sometimes we're even like, once we get their specialist records, especially if they're new, we find out a whole lot more of information on them. So this is the code if you would have a patient that is just the pillar of health in the Medicare world. Which screen can you guys see? I have two screens here. Okay. The GO 557 is going to probably be the majority of your patients. This is the two or more chronic conditions, kind of the same, pretty much the same guidelines as what we have now. So they did decrease the rate to the $50 per month. They're hoping that you're going to use, well, we can't use the add-on codes anymore on this, but they're thinking this is kind of the majority of the Medicare population. And it probably will be. This is the one that I'm still really digging into, and I'm using this actually right now in long-term care, the GO 558. So they have to be dual enrolled for this higher level of reimbursement. This is about $110 a month. And they have to be a qualified Medicare beneficiary. And you have to be able to look that up. And from what I have seen already, sometimes it changes. So it's something that we are looking up every month before we bill this. And again, this has been a big one in long-term care. I love CC. This is a whole different conference. I love CCM in long-term care. We started doing that because there was such a need. We have patients that don't have any family members. We have patients that just weren't quite getting care. So we have a CCM actually go in there. We're doing a lot of face-to-face. We don't bill for that time. We bill for all the stuff on the back end. If we have to get them coordinated with the social worker, or if we need to communicate with the provider about, you know, any of their conditions or anything that's going on, it's kind of an extra set of eyes. This is also the population that was really making a big impact in our shared savings and ACO. So our ACO was taking a big hit because these patients are in the hospital. They're admitted all the time. They're in the ER. I mean, that's just what happens with this patient population. If we weren't doing Medicare wellness visits on this patient population, then we were never really showing Medicare how sick or not sick these patients were. So if we can go in and drop all those chronic conditions, or we can get them excluded for different buckets, then we made a bigger impact in long-term care. So this is the one we're really working, because we have a lot of Medicare and Medicaid patients right now in long-term care. Any questions on that? Has anybody started using the APCM program yet? from what I have read, what we're doing, you can go between both right now. So you could technically do your dual patients in this program, and you could still build a 99490, the add-on code, or your GO 511. That will probably go away next year. As soon as it seems like it's a good idea and it's going really well, they'll probably chop it.
We thought you had to do one or the other.
No, you
Yeah,
can go
you
between.
build them together, but one month you can do APCM and one month you can do CCM.
Now, I would keep the same patient in the same,
Yeah,
So
I
one
think you
per
can
month.
bounce back
You
and forth,
can't.
literally, that's
You
what
can't.
you're saying.
yeah.
But I don't think you can build both together.
No, not till close together.
Okay.
Not together.
Okay.
So for
Well,
long-term
that's-
care, we're doing these particular patients, or if we have, I could also do, you know, for patient in room 200, I could do the 99490, and the patient in 202, I could do the APCM.
Yes.
I don't think that's going away.
I don't know.
Oh.
I said, as soon as it thinks it might be a good idea, it's rolling really well, they'll probably change all the rules.
Right.
But that's the way I can do the add-on code, and we can kind of capture some more of that basically than just doing that $50 for that GO 557 code. So yeah.
I think the perk on this one was this wasn't time-based.
Right.
Yeah.
And when you don't have the EMR that tracks your time, although it sounds like you're sending claims out without time tracking, which is interesting. to me.
Yes, we put all of our time, I know, yeah, no,
So
we
how
do
does
everything start to finish, so you can track time. But you also can't track time like when we're within the clinic, or sometimes we're out in patients' homes, we've actually had to go out to patients' homes and there's no way to. Or if you're on the phone, stop, so everything that you do is start to finish, and so that's why we built the templates.
And
They're not
you're-
check boxes.
Right, so
They
if
don't
you're
like
getting
that.
audited, you say this template, if all the boxes are checked, took us 20 minutes. I'm just curious, that's.
No, we don't do check boxes at all.
Oh.
CMS doesn't like check boxes. And if you go into certain EMRs, they have created CCM templates that are checkboxed.
Oh, great.
So we avoid all of that.
And
So
you're not
no,
having any problem being audited for minimum of 20 minutes. You're not-
right, we always do 20, it's 20 minutes or more, of course.
Right,
And it's built by template. So this template is at least 20 minutes or more. If we have time, like sometimes you might spend 27 minutes on the phone with a patient, that is all documented. But then if we're calling for records and the provider's reviewing time, then that's all, you know, whole other set of time too. So,
interesting.
so, yeah. And our EMR doesn't really track time. So you can do documentation or you can time track.
Question.
Oh.
Chat. What two codes can be built together on a patient?
The 99490 and the 99439. Those two codes. You have to build 490 first. That's 20 minutes. And then if you do 20 minutes or more on top of that, that would be the 99439. And again, there's a lot of codes. I actually thought, Rue, about adding that one that I sent you of all the rural health codes for 2025, but it's a bit overwhelming.
I might have a slide with that. Stay tuned. I didn't put them all in the slide, I gave you a link, but yeah.
Is
There's
there
a lot.
amount of how many times you can build a 99439
No,
just for each additional 20 minutes?
Yeah, and it's minimum, you have to hit 20. You can't go for.
yeah, no,
Okay.
can't be part. But you could also use that 60-minute code,
Mhm.
you know, yeah. So no, there is no, right now, as of right now, there is no,
Okay, I just wanted, that's what I thought.
Yeah. which I mean, if you really look at all the time, I mean, it's 30 days, 31 days worth of work. The biggest thing is going into the clinic is making sure, you know, you're not the only person that does CCM. It is every single person in that back office, that whole care team does CCM. So that's why we do the templates. So we can capture, and we'll get into this when we talk about billing. It's capturing all that clinic time. You know, they did a pre-cert on a patient, the patient called and we had to change their hypertensive medication. The nurse got on the phone and had to do some extra education. You can capture all that within communications and you can put that into a template. And then because there's no time on that, then we can add our templates in.
Why would you not, if you can quantity build the 99439, why would you not do that times 3 instead of the 60 minutes because you're gonna get paid more?
Yeah, you could. Yeah.
Okay, so it's just, that's just the
Yeah,
way
I have not seen the MUE, I have not seen a medically unlikely edit hit for that number, but it might, I mean, if anybody, I just haven't seen it go.
The GO 511, you were able to quantity it last
No,
year? Yeah.
yes. I
But
see what
last
you
year
mean.
you were able to quantity it and sometimes they would get kicked out. I had one clinic that did it 5 times and it paid. And I had another one that did it 3 times and it denied. So it was very hit or miss. I think these will be better because they are specific codes. So they have to pay on each code versus a quantity. Now, the 99487 is the complex chronic care management. It has some different requirements. So if you have your patient, that's just your 2 or more chronic conditions, you can do 99490, 99439. If it's more in depth, you can use that complex code.
And I think you had another question, you may want to look at this, your reimbursement rate for then the first 20 minutes and then the add-ons. If you had a 60 minutes total, look and see what your reimbursement is on the complex. It might be a higher RVU all overall, you might get more reimbursement just use the complex versus the 320 minutes or the 220 minutes in your first one. I mean, it's
really
really
been different by payer, like some
Yes.
of our plans are paying us our all-inclusive rate for care management, which is great. I mean, it works out great for us. But it's very different by payer.
Yes, it has
There's,
been.
I don't know.
Yeah, it is. So that you're asking why would you, that might be why. Like
Yeah.
you may be doing it because you're getting better reimbursement from the 160-minute code than piecing out the others. But it's really tough because it's organizational specific to your contract.
Yeah.
It is. And that's what we've really had to dive into.
It's crazy.
I mean, almost the last 3 years, every year it's changed to something
Yeah,
else. So
right.
for staff, you want them to kind of stick to the script.
Right.
Then on the back end, we get to go in and figure out why, who, when, where, why aren't they paying? We resubmit a lot. And then they go through just fine. It's like, why was it rejected the first time and it was paid for the second time? So yeah. So I haven't built one of these just yet. We're building and making sure we have all the requirements and making sure we have the templates for our EMR. We actually went with a different EMR for long-term care. It's more of a documentation tool. So we're building these templates into there right now. I was hoping to maybe get one back before I came here so I could be like, guess what? They didn't pay anything. But it's not what happened. These are the different ways if you need to see if they are a QMB member. We use WPS. And it's also by your state Medicaid, so it will be specified in there. We do cyber checks for Missouri Medicaid to see if they are a qualified member. And again, I would look every single month if you're going to build this code for now, because right now it looks like they kind of come in and out, which I'm not really sure why. I guess that would have to do with maybe eligibility.
On the Medicaid
The
side.
Medicaid side, yeah. Yeah. This is just a little bit more since this is administered by state for the Medicaid program, you will need to check your state, per state, to see what their portal looks like. And then it said in some states, they will actually show it on the ID card. Ours does not. So you guys might check if you look at your Michigan Medicaid and see if it actually specifies on the card or not. It does not for Missouri. It does not. Okay. Of course it
Check
can be.
C-SNAP.
What? Yeah. Yeah.
Is that what you check?
Uh-huh.
Okay.
It doesn't go out on I'm just curious, asking when you check it in on your eligibility checking software, does that ping back? Like when you're checking a patient,
We
you
don't
have
have
that
eligibility software. We manually do it. We had it before through our EMR and it was terrible.
Thank you. That's what we're
Copays
at.
were wrong. It was just, yeah, it was nuts.
Yeah.
And we get charged. And then they would be down all the time. And
Yeah,
couldn't
we
trust.
were,
Yeah.
we were paying a monthly fee and it just
Yeah.
wasn't like an accurate.
So they use that, or they use the cyber access. A lot of us have cyber access for Missouri Medicaid. You can check, anything on there.
Yeah.
Different ways to maximize the billing code. So we kind of talked about this. And so this is always touchy because I know we spend a lot of time on the patients. And we want to maximize that. But at the end of the day, if the patient comes in and they have a higher copay, we have to bill them that copay every single month. I don't want to take a chance on losing that monthly interaction with that patient just because of the copay. At the end of the day, the copay doesn't matter to the organization. We do not care. It matters more to us that they stay in the program all year. We're going to have better compliance. We're going to have better ACO numbers. And we're going to save the patient actually a lot of money. But you can't tell the patient, well, if you go into the hospital one time, you're going to prevent, 20% that you would have to pay for a hospital admission. They just see that monthly bill coming through. So that is always something that we're always tackling. We don't actually have we have a third-party biller outsource how do I want to say it? We don't send anybody to collections. The problem with that is when the patients call them, they don't understand what CCM is. And so they'll say, well, I don't think you should be getting billed for a day you weren't seen. And it created a whole bunch of, drama in the very beginning. And so this is why I always educate with the CCM people, make them bring those statements to you. Make them bring them to the office. Do not call, just have a conversation with them. We have to bill them the copay. But we don't care about the copay, but we have to tell them to pay the copay. We can't say don't pay the copay. What we do say, I forgot the auditors here. What we can say, just kidding, is sign up for sliding scale or patient assistance. So just make sure you have a good program with your sliding scale patient assistance. Make sure those patients are signed off. And that is a way to write off that CCM copay. Conducting monthly audits, billing opportunities, if you are time tracking. So we did have a long-term care group that LLC, their CCM. And so they send through all of these codes that come through and it's time. And there's a whole bunch of time down there that just doesn't get hit. It might be 16 minutes, 15 minutes, all that type of stuff. So we've actually put a person in to kind of review all of that stuff and kind of do some outreach to the patient, make sure we have care plans. So if you're time tracking, you definitely want to make sure that someone is reviewing all of the time because you don't want to leave anything on the table. We do everything start to finish. So we bill as we go and we get through every patient every month unless something happens or they're out, someone's out or something. But even if they're off, they want to get through their patients every month. Strategies to address. So this is just a lot of work that we do. You want to make sure that you're working with your chronic care managers. Do they have a load that's too large? Do they need help? A lot of times we will go in with organizations and we will show, what their potential for their CCM enrollment is. So we might say that you have 150 patients enrolled right now, but through the data capture and the analytics, we can see that you have the potential for 350 patients. Well, that would probably warrant hiring another chronic care manager. So being able to see the data and using your EMR to be able to pull that type of data, you can see how many patients are walking through the door, how many are Medicare and Medicare Advantage. Michigan's also so lucky because you guys have those beautiful blues. I call them those beautiful blue codes. Because you guys are very lucky. I haven't seen that anywhere else where you have the different care management codes. Do you use those a lot?
I don't know. I've never heard that in my life.
Yeah.
No idea.
Yeah.
GDCM.
Oh, yeah, yeah,
Okay, yeah.
Yeah.
I call them something different. because
Yes,
they're-
okay, yeah.
These are chronic care management, and then you have those beautiful blues.
Oh, yeah, we've been doing those for years.
Yes, you guys are very lucky. I really love those. And so a lot of times when we go in and we dive into the billing, you can see where they're kind of crossing swords. They might have a blue, but they're using the GO 511. And so you want to make sure that you really do a lot of education and do audits on the back end so you can see who's paying, what's paying, because you can go back and, rebuild those if you need to.
So we were told that for our Medicare Advantage, our Blue Cross and Blue Care Network, we have to bill just the G0511.
Oh.
So we don't get to bill the other.
Yeah.
codes.
So I thought it was a whole different code altogether. Bree, what is the code for blue?
You're right.
Yeah.
So I'm confused.
So G0511 for the chronic care management,
For Medicare Advantage,
for Medicare plus Blue told us we have to bill that.
the GO511 until July.
Let's chat about that.
Yeah, I'm gonna
Yeah,
write that.
let's sidebar that.
Yeah.
Because when we were diving in, your blues typically are paying better on their blue code, which is a whole different code. I didn't write. I have
Priority
those
Health
in my
says,
book.
Priority Health
Yes.
Medicare Advantage said the same thing.
They did too?
Yeah.
But I've
No,
seen them
whatever.
paying on the blues.
They're paying us our all inclusive rate, so
Yeah.
I'm fine with it.
Yeah, yeah.
But I'm just, like, they told us we could not bill the individual code.
No, not those
The new-
codes. They would be your,
Oh, for the PDCM.
yeah.
Yeah, they told us the same thing. We have to bill G0511.
Lisa Allen from the chat said there are 12 PDCM codes for commercial plans.
Yeah.
So what about Medicare Advantage? That's where we were told we
Carrie.
could not bill it as an RHC. We had to bill G05.
Interesting. I've seen them pay in Michigan on some of those other codes and stuff. And Priority Health. And Priority Health.
Yeah, they both, well, yeah, they'll pay.
Yeah. they did.
So that came from Lori Doctor, who's the
So
Michigan.
with Rue and
Blue
them,
Cross.
we were diving into a lot of the claims and stuff, which is where I get all my answers, because you can see everything per payer, when what they rejected, why they rejected the EOB. So yeah, this year has been really crazy because they changed the codes again. From last year, they said you could quantity bill, and now they're like, we can use the GO511 until this time. Here's a whole bunch of add-on codes. So it has been a little bit crazy. So far, they're paying a little bit on everything. But yeah, I want to look into that. I want to talk to you more about that.
Okay, but you're saying you can bill all 12 of those PDCM codes to Medicare Advantage? Blue Cross Blue Shield?
Is this on?
I don't think we know the answer to that.
Oh,
No,
okay.
it's been a little bit hit and miss, so, yeah.
They recommend that they RHC.
Carrie
Yeah.
from online, did you want to ask a question? I saw you unmuted.
I was just gonna say, this is Carrie, care manager at Sure. And we have seen, I have seen it both, like on my Medicare Plus Blue patients. Once in a while, I will see them show up on my commercial paid claims report that we get back showing like how many touches we've had for our Blue Cross patients. So I've seen it. It doesn't always happen, but I have seen our Medicare Plus Blue patients come through on that report that they've been paid for the commercial side.
Because they will count the G0511 for those touches. So it would show up on that report, even if we're billing the G0511.
Thanks, Carrie.
No, and I've seen it actually come up like through a minute code, like where they've pushed through it differently for the Medicare Plus Blue. I mean, I would have to pull it up, an example up to find it, but not just the G0511.
Okay.
And then another comment, for the 12 PDCM codes for commercial plans. Lisa says, I believe it has to do with the RHCs and FQHCs billing on a UB.
Mhm. It's very true. That's something that we've been doing through, and that is where we can kind of go through and review everything on the back end to see what's going through and what's not going through, especially January and February. We had a lot of the denials of the 99490 initially. They were all being denied the first of the year. And we were like, come on, you told us we could use this code. So yeah, that's why I was like, Michigan, you guys have all of these beautiful codes that you can use. So just making sure these are Medicare Advantage. Another question. So this is just identifying and addressing any missed billing issues. So this type of stuff. So being able to go back and go through with the coders and review missed claims, unpaid claims is a big one. Sometimes it just happens to do with the 30-day rule. We don't have reoccurring visits because our EMR wasn't able to do the recurring visits. So we couldn't drop the visit on the last day of the month. So we have to bill as we go. So just being able to go through, sometimes the Medicare Advantage will kick out if it's been, 27 days, 26 days, we have to resubmit those. It has to be 30 days worth of work. Traditional Medicare goes right through, no issues. Managing the CCM copays and patient participation. So this is the one where if you have a good patient assistance, you want to make sure everybody is on board. Everybody understands that if you have a Medicare patient that doesn't have a secondary, a lot of times they are underinsured and they are low income. So we want to make sure that we can outreach to those patients and let them know that they might get a bill. We have to send a bill for so many months based on whatever your policy is within your organization. But the quicker you can get them signed up for your patient assistance, the quicker you can write that copay off. Does anybody have any issues with copays? What are some of your issues with copays that you run across? Because I feel like this is, they don't, yeah.
They get upset.
Yeah.
They can't afford it.
Exactly.
That's the bottom line.
Yeah. Yeah.
So are they paying copay on your?
Paying for your medication or going to the grocery store.
Exactly.
Already putting them medication and their groceries.
What is the copay? Like 20% of how much of your AIR or what is it?
Yeah.
It's usually like $8.
$8 is like 14.
That depends on if they have a Medicare Advantage plan.
Yeah.
Right there, that's the majority of our problems right there.
Yeah, so this is always an issue. So this is why I don't really want them to go through billing to talk to them. I'd rather them talk to their care manager about these types of issues. We've been able to overcome a lot of obstacles just by them talking to that person they talk to all the time anyway. If they can understand the importance of the program, great. Sometimes they do not. Sometimes they do not care. But you have to find a way to be able to not care about that copay. I don't like them harping at the front desk, you need to pay your copay, especially when it's a CCM claim. However, we got to treat all copays the same. So making sure that everybody is on the same page with the CCM copays, and getting that paperwork out. We have now started introducing the paperwork right at the very beginning for the sliding scale and the patient assistance if they're only Medicare.
That's the hard part. It's very difficult, as we're explaining to the patient exactly what the program entails, right? How it's going to benefit them and how it's an extension of our team that, may not be in the office. These are all the wonderful things that they're going to do. We understand that side.
They do not.
Right?
they can't build that rapport if they don't sign up. They don't sign up, they don't get the benefits, right? So it's kind of that evil catch 22 where I can't sell it. I can sell it all day long, but until they actually experience it, and that's the barrier. There's this chasm where everything kind of falls in that middle because they're not willing to make that $20 investment.
Right,
Even though there could be some benefits in them.
Right.
Just can't overcome that, no matter the verbiage, no matter, you know, how wonderful we think it is. Right now, I'm selling a fruit punch bowl and telling them it tastes like champagne.
right.
That's really what it comes down to.
It is.
So it's a huge challenge. One of the things that we are attempting to do is putting the information in front of the patient, like at their new patient appointment, and signing everything up front as part of our team and putting more emphasis on it. We're doing a pilot, but I haven't seen any benefit. We haven't fully started it yet, so that's the only next step that we've come up with to get them interested. I guess stay tuned, but we haven't overcome that.
Yes. One of the things we've run across is, we had people that were reaching out and calling patients to get them enrolled, and that just wasn't working. A lot of people get, spam calls, they're not sure who you are. So I completely took that off the table, and we only enroll based on the patients that are walking through the door. That helps. It kind of starts at the front desk. The front desk can introduce the concept. They're not enrolling them, they're just flagging that patient. Then it will go to the care manager. If they decline, it goes with the nurse or the MA. They educate the patient. And then if they still don't want to, the provider goes in. I have some providers that will walk out with that signed consent because they stress the importance of the program to the patient. They stress this is an extra set of eyes on you for me that I need to better take care of you. So everybody kind of has their own different approach, but just kind of setting the guidelines for the staff so that everybody understands, if you don't get it, it goes next. Some of them just flag the patient and then the chronic care manager calls and details the program further. Some only want it to come from clinical staff or the provider, and that works too. But getting it in the office has definitely made a bigger impact than calling.
Well, and that's part of the problem. Our care managers aren't even within the four walls of our clinic. They are remote because they cover a large.
Yes.
They're employed by us.
Yeah.
Because we're not using a different vendor to do this. But the problem is, they don't know who Susie is.
Exactly.
Right? They've never seen Susie. I can show them a picture, but there's no connection to Susie. So again, I'm selling.
Yes, exactly.
The provider's where it's gonna be driving. That's how we had to drive with our ACO.
Yes.
Visits. It had to come on that provider's mouth. And that provider could make them understand how important, and I really feel like that's the winners, letting the provider be the driver.
Yes. I've also had really great success with hiring chronic care managers that already worked in the clinic. They wanted to change, and I was able to kind of bring them over, and they realized I was pretty cool to work for. So that was a big one. We started getting a lot of patients involved because they wanted to stick with that particular nurse or MA. So you've got to get creative a lot of times, getting a team-based approach, making sure everybody is on the same page, the sliding scale, that can really help overall. Another. You said something.
Provider driving it?
Provider driving. Yes, the provider driving is a big part of the buy-in as well. A big part of the buy-in for us was when they realized that patient was going to be enrolled in chronic care management, we did Medicare wellness paperwork. So the providers got on board real quick because they didn't want to have to deal with all the paperwork. So, and we don't bill for anything associated with the Medicare wellness visit. They pay that rate. We don't bill for any of that, but we have all the answers to the test because we're tracking that information. So it was easier for us to prep that, to call that patient. We're on the phone with them anyway, and go ahead and knock out a lot of those questions prior to them coming in. So that was a big buy-in. We bonus our providers on CCM. That was a big buy-in. We have a rate for MPs and we have a rate for MDs. That is a big one because at the end of the day, it's not about that monthly rate that's coming in. It's about you're going to increase your Medicare wellness visits. You're going to boost volume. You're going to perform better in your ACO. You're going to perform better in your value-based care programs. So we were able to generate a lot of revenue just based off of that one CCM encounter. We were able to hire a lot more staff. We were able to hire more community health workers. We are very lucky in the fact that we have another PCHH program, which is a Medicaid program in Missouri, and they have to have community health workers. But we're also able to hire and use community health workers. So with our social determinants of health, we're actually capturing that CHI enrollment right now. If they fail the social determinant of health, they're immediately enrolled with a community health worker. We have our wellness nurses doing that during that visit. And that's a 60-minute all-inclusive. It's a real lengthy template in the beginning. But if they are homeless, they don't have food or can't get medications, they're hitting that easily anyway, because they're usually reaching out for outside resources. So one thing kind of led to another, and it's just really grown to what it is now, to where we have extra staff now just based off of that monthly CCM enrollment. Kind of went over this. Billing practices is crucial for compliance, of course. Trust, and this is where I come back to this, because this is where that chronic care manager just has all of the impact in the world on these patients. Sometimes when we work with different, what did we have last week? She was an RN and I was like, plug the bullet hole. And she was like, I can't. She wanted to go through a single thing for the patient, you know, and I was like, we have got to plug the bullet hole and move on to next month. We're going to address the sprained ankle, the abrasions, and all of that next month. We want to try to help patients as we possibly can. And so a lot of times learning how to move through your patients effectively by using your provider recommendations, using your standard of care, using all of your standing orders, you know, we just want to make sure the patient is taken care of from appointment to appointment. So anything that may fall through the cracks. Yes.
Jill, so you mentioned next month.
Next month.
Okay, yeah, but I thought we could bill the 99490 multiple times throughout the month. So why can't that patient come back next week?
So for these particular codes, we're just going to drop it on one date of service. So that has to be one date of service. Now you can do all of the work throughout the month, but for the RHCs and the Medicare and Medicare Advantage, you can only drop those. The 99490, you can drop multiple increments of the add-on code. So you can track all your work through the month and bill it, but it's all going to go out on one claim. If that makes sense. But yeah, your blues, there's a whole lot of really cool stuff. I'm so jelly. So the CCM manager is a big one to keep the patients in the program. Sometimes we still have those patients that they do not care. I actually, when I was actively running the team, I had a patient who came and we talked to every single month, and he came in and I got him samples. And he didn't want to get that copay anymore. And so I had to take him out of the program. And when he realized that he couldn't talk to me anymore, he wanted another consent, and he signed it right away and came right back into the program. And he could afford the copay. It wasn't that. But he liked that I kind of called it the VIP treatment. You know, he didn't have to go through all of the steps of the clinic to get to me. He knew that I would see if something was going on, and I was going to jump in, and I was going to help him immediately. Now, you don't want them calling you for everything throughout the month, because then you get to where you can't get through all of your patients. But another buy-in for our clinics was those patients that do call all the time and need that extra attention. You know, we kind of took them on, not that we're talking to them all the time anymore. Now, because they do have us and they do have more attention, they don't call as much anymore because they know we're going to be calling and checking on them. The power, teamwork, and CCM. And this is just about that whole team approach, the front desk, every single person from the top all the way down to the bottom, and the bottom all the way up to the top. When everybody is aware of CCM and the impact and the power of CCM, you're going to have a much better overall production rate. There is my contact information. My partner, Jessica Schroeder, she's a genius. She's great. She's good with all the data analytic type of stuff. And identifying through different EMRs, how can we find this patient population? Who are our eligible patients? So if you guys need anything, there's my information. Any questions? Oh, I heard. Awesome. Yes.
So what caseload do you have for care manager?
Yes. Okay. So in our wonderful TrueBridge CPSI EMR, we have to create the visits, and it's about 25 steps. And it takes quite a bit of time to go through and have to create each encounter. So I have about 150 to 200 per manager. Okay. Now that's not every single person, because I have a lot of little RHCs. So I might have somebody that only has 50 to 75 patients, but she's also drawing labs 2 days a week. And, you know, she does pre-certs. So we kind of dual them throughout. It's important to know that, because you have to kind of carve them out for the cost report. Yeah. But if you can hire someone that you can use in other avenues, if you don't have a full caseload, it really does. That helps a lot.
Do they do like transition of care calls? They do those as well?
Yes, okay. If we can, so we have a list of that comes out. That's really hard for us to capture, because we're not always notified except through this crazy little improve on the back end of
How it's
CPSI.
billed, it's not like you can pull that out of how it's billed.
Yeah.
Justify that.
Yeah. So we just started that for 2025.
Okay.
So everybody's attacking that transition of care. The CCMs are the ones that are responsible for pulling any Medicare. It's not just CCM, because if we can get a Medicare patient in, that's an opportunity to get the patient enrolled. But that's where that hospital discharge. So we capture the TCM, we capture the visit, and then we always send a hospital discharge care plan for our CCM for the time for that. Yes.
Do you have like a billing goal per day, like just to kind of maintain financial stability?
Yeah. And it's not even for,
patient.
it's not even for finance. It's really hard to see what people were doing when COVID happened. We had people working at home and, you know, we would pull a group out because then when they weren't sick, we would pull them back in and all that stuff. And CCM can be very boring also when you're just very monotonous. We don't have a lot of space in a lot of our clinics. So sometimes they're in little dungeons. So I try to get creative with where they are. You know, I try to give them a day or so a week to be able to work from home. Some people are really great at it. Some people really aren't. So for that reason, I usually tell them about 50 patients a week, 40 to 50, depending on their role. That's 10 a day. That's very manageable if you have someone. We also started digging into their work and home days. And if you're like, wow, you didn't bill any patients, that's weird, you know?
Yeah.
So yeah, you have to get kind of creative sometimes,
Yeah,
but
we careful with the clinics and we didn't have rooms like your manager.
yes.
Yeah.
And in that case, you can pull them out
Yeah.
because they can
We do
still
that, we just
be,
centralize
yeah,
it now.
as long as they can communicate with the care team.
Yeah.
What we have found for third-party vendors, when we go in and look at their notes and stuff, it's a lot of copying for just random stuff. There's not really a lot of interaction going with the care team. And so we want to make sure that person is diving into the last office visit. Did the provider prescribe new medication? Did they fill it? You know, we want to make sure they're part of the care team. So you can pull them out. But yeah, we've had to get creative sometimes just with space.
Yeah.
Yeah.
Thank you.
Yeah. Thank you, guys. I'll be here all weekend if you have any questions.
Okay. So with that, as I mentioned before, you know, we have certain fundings and programs that we get to do through the State Office of Rural Health, through our flex dollars. And one of the things that we have been able to do this year, as well as last year, is to sponsor some clinics to have one-on-one consultation with Jill and Jessica to come into your clinic, to do an assessment, to look through the workflow, to look through the design of your program, what's working, what's not, to do some staff training, to do some patient engagement strategies, how to build that relationship, how to get them to enroll, how to really talk about that value of the program. And we will have 4 more spots this year. We did 3 spots last year. And as you heard Jill reference Rue, she's worked with Rue's clinic. They work on a one-to-one basis. They usually come out and do a site visit to be able to talk to the front end staff, to talk to the care managers, to talk to the providers, to talk to any clinical staff like MAs, but then also to talk to the billing staff and everybody in between. So when you look at CCM, it is truly from the very moment that patient is even thought about being a CCM patient through getting that patient billed. I know Jill can tell you some stories about some of the things that they've discovered at working one-on-one with clinics and some of the challenges and some of the things that they've been able to fix. So again, I have 4 spots. It's at no cost to the clinic. We are absorbing the cost and contracting with Jill and Jessica to make that available. If you're interested, please email me. It will be on a first come, first served basis. Ideally, we'd like you to be able to, of course, commit to the program, commit to working with them. But ultimately, this is a benefit to you and your CCM program in your clinic. We know CCM can be a huge benefit, especially when it's done well and you're actually getting paid for your visits. So it can be self-sustaining and it can also add some additional revenue. Again, if you're interested, email me. I will connect a one-on-one appointment with you, Jill, and myself to get things connected and started. And then I let them run with it. So they've done a fantastic job. Rue, do you have any comments with regards to Jill? And only nice things, please.
We have a good time.
We do. It has been an absolute
pleasure. And she has brought a lot of education and a lot of resources, and it's just been a great experience. So.
Awesome, thank you.
And just so everyone knows what it looks like, we just visit about, in the beginning, we will do an hour or two a week, sometimes it's 2 to 4 hours. And we just sit with your person one-on-one and we start training them. So it is not a big time commitment. We usually go down to once a week and then we go down once to every other week. And our job is to kind of be in, get you guys rolling and then out. But room knows we're always available for emails, calls. I'll probably never break up this room.
She has had some people. That's fine.
It's really meant as like a start and a finish, and Rue forgot the finish part.
I just asked her, you're not gonna dump me, are you?
So again, this is an opportunity for you. We'd love to be able to support these kind of things. One of the unique things that we're able to do as a state office of rural health that's independent versus some of those that are part of state government and part of the university. We get to make up our own rules sometimes. And this is one of the things that I absolutely love to do, is to be able to give back to the clinics and give them a resource. So we have one more speaker, and I know Jill went through some of the billing and coding, but now we have our true expert.
It's gonna be hard to follow that. It's not gonna be that exciting.
But that true expert is when you really get paid for the things. We've worked with Arch Pro Coding and Billing for, I don't know how many years. John Burns, Gary Lucas, John Beard. We actually have a billing and coding workshop scheduled for May. So if you have someone from your organization that could use additional training on all things billing and coding, make sure you sign up. It's on our webpage. And Aaliyah will put the link in the chat. So if you're online, again, we have a billing and coding workshop that's coming up in May. But more importantly, we have someone in person who can answer some of your challenging questions, go through some different information. She's got a slide deck and I'll pull that up.
You're awesome.
I know, I thought it was too, but it seems to be missing out of my. Love
So just so you know, the folks in the back, if you come up and talk to me, I can't see your faces. You're silhouettes.
You are, you're like this glowing little angels
So
in
if
the
I,
back.
if I happen to walk right past you later, it's because I can't see your face. I just want you to know that. It's weird for me as a speaker not to be able to make eye contact. But I like the light, so.
Share.
Smile through.
Good on that end?
Yep.
Okay.
There's no polling involved, I promise you. No more polls.
All you have to do is just click down.
Okay, thank you. Thank you. So hello, and we're gonna talk about capturing every dollar and optimizing your coding and billing. So focusing more on diabetic care, and there's no clickers, right? So what are we doing? Hitting the down arrow?
Gonna go your down arrow.
Okay, very good. Okay, cool. All right, so my name's Jackie King, and this is not moving on this slide. Fun technology.
No, you think you got this. You think you have this every single time, and then it just. You would think that it would just be easy, but it's not. I wish that it was.
You're doing great. Well, we'll go to the second slide. I'll tell you who I am. So I'm Jackie King. I have been with Arch Pro Coding for 5.5 or 6 years. Before that, I was working with Illinois Critical Access Hospital Network, which is sort of the Center for Rural Health that gives the flex and SHIP funds in the state of Illinois. So we are not academia, we are not government, we are just a critical access hospital network. And I found them through working at a critical access hospital. I worked in fee-for-service, small rural fee-for-service. I hate to even say this, I've been in healthcare for over 35 years. I was a clinician, an x-ray tech, and then I moved into more administrative roles because I literally don't like snot. So that was the end of being an x-ray tech. So a lot of experience though working at hospital, medium-sized hospitals, et cetera. started working at a critical access hospital back in like 2013. And literally for about 6 months, I thought I was going to jail for fraud by looking at the way they were billing. They had a rural health clinic and a critical access hospital, and I was coming from fee for service. I'm like, you can't do that. And I kept being told, what's the cost report? It's cost-based reporting. It was quite a challenge. So I did learn a lot by trial by fire. My predecessor had passed away suddenly, and it was a very small hospital, and I didn't get a lot of training. So I feel like I've learned the hard way, a lot of ways. And throughout working with that hospital, I became part of the Illinois Critical Access Hospital Network. Just Bill. Okay, let's hit the, like that. There we go. And then I'm still talking about myself. Let me go back there just for fun. Found Arch Pro Coding. So Arch Pro Coding did a rural health clinic boot camp, which is what they're offering. And is it free?
It's $50.
$50. This is like a really good deal. So did that for our rural health clinics in Illinois. We have now about 55 critical access hospitals, and everyone has at least one, and some have 17 rural health clinics. Okay, so there's a critical access hospital one coming, I think, in August at some point. But I learned a lot, and as they would have their teaching, it was John Burns one year, it was Gary one year. That was my job to get education. John Beard, the founder of this company, said, what about critical access? You know, can you do that? And I ended up building that similar. So that's what I do all the time. But we also have an ACO with 26 rural hospitals. They just finally made shared savings with Medicare last year. We were getting shared savings with Blue Cross Blue Shield of Illinois for the whole time. So they were founded that thing started in probably 2016. But it's for rural. It took that long to figure out. But I will tell you, CCM is one of the key performance indicators. Medicare Well, CCM, TCM. Those are your three big players. And what we're doing with all those wonderful things is keeping our patients out of the hospital when they don't belong, taking care of them in an ambulatory outpatient, keeping them connected to your primary care doctors. Let that be your gatekeeper for everything else that goes on with that patient. I just can't stress it enough. My email address is on the slide. If you call that number, you'll get somebody in Georgia, because the rest of my team lives in Georgia, but I live in Northwest Illinois, rural, about 30 minutes from the Mississippi River. So it's beautiful here. We do have a few more flowers, but it's similar, but it's gorgeous. I love it. Looks a lot like Illinois here. So we'll talk about some resources and references. Jill asked me to pull together. She gave me the Moline and the Meridian provider manual just to look at what you could be looking at from your Medicaid payer, anything kind of incentive wise we could look at. Then getting into documentation and coding, and the record is the source of truth. It has to be documented, and we can't bill it. We can't code it. So I have very steadfast coders with their heels in the ground, and they're doing that for a darn good reason, because we don't want to fail an audit and give any of our money back. We want you to keep all the money. We want you to get every penny you've got coming, but not a penny more than you earned. So coders have to pretty much kick their heels in and say, you didn't write it down, I can't do it. Coders should always be feeding back to our providers opportunities for better documentation, improvement, all of those things. But if it passes through and lands on the note, that's all we have is the note. So we really try to work with clinical documentation improvement, even in a rural health clinic setting, but in a hospital setting as well. And then some quality metrics. We are now allowed, as of April 1st, to bill category 2 HCPCS codes on our claims. Category 2, yes. So I threw that together as best as I could. I did not touch behavioral health or mental health. That is not my bailiwick. So I really didn't pull anything in there, but I know somebody here. So if you have behavioral health or mental health coding or billing issues, we can follow up and ask us later. So a couple disclaimers. The contents that I'm giving you are copyrighted. Most of it's coming out of CMS and your payer manuals anyway. So feel free to share it among your groups. Just don't package it up and sell it outside. And CPT is going to be used. We're going to reference CPT. They are owned, operated, and written by the American Medical Association. So we'd have no ownership rights. All of their rights are reserved, but we do use those to code and bill. So I'm going to mention that. A couple more things. Well, I really can't. I don't know where the answer is. Here we go. When I'm giving you this, it's based on my research, some guidance, some training. It's opinions. I'm not a lawyer. Your tax ID goes out on your claim, not my tax ID. So just be careful with that, okay? Your organization is responsible for making sure you're following your billing rules. You're gonna have different state rules. You're gonna each have your own payer contracts with your commercials. So that's pretty much what we're saying. Just double check everything before you go make any changes based off what Jackie told you today. That's what we're gonna talk about. So some references and resources. The National Committee for Quality Assurance, the NCQA, is what's driving a lot of our quality metrics. So if you go into your slides, you should be able to click, there should be links inside of here. And I just wanted to bring that slide up. It's kind of a little slide, but that's what it looks like when you go out. And HEDIS measures are what we mentioned earlier. HEDIS measures are driven a lot of times by category 2 CPT codes, but many times also just by CPT codes. By doing a service, it'll check the box. So there's various ways that you can be looking at these measures. So claim-based reporting, if somebody's on a statin, the only way we're going to know is if we get the statin filled. You know, they're going to get the claim, they're going to get the prescription filled every month. I'm on a statin and I get mine filled every month. And that's how we know the patient is compliant. I mean, they could be filling it every month and dumping it down the trash. But the point is, there are claims-based, there are CPT category 2 based, and also just coding by doing a code. So just know that there's a lot of variables, and this is, you know, a 45 minutes presentation. So here are the diabetic related measures for HEDIS, and we're focusing on diabetes. So blood pressure control for patients with diabetes, eye exam, mention that for patients with diabetes, the glycemic status assessment, so the A1C, kidney health assessment and evaluation, and then the statin therapy. As you're looking at these, each one of these is a link to the NCQA website and read all about them. I won't open any links. I have no idea what that will do to us. So this is pulling from the Medicaid Meridian MCO manual. I know there's more than 2. There's a lot.
We have 9 in the state of Michigan.
9 managed care organizations. So Illinois has 5. But wow. But I wanted to look and see. So this is a provider manual. This is where they're giving you performance criteria. They're actually delineating the age range, the specifications. And when you're looking inside of this, this is good for you to know because there are pay for performance measures inside of here. So if you weren't familiar with that, here goes the glasses again. They're looking at your HEDIS measures. They're looking at what percentile of your patients, and the ones with the red arrow are diabetic related measures that I just mentioned. So you're getting extra reimbursement from Meridian. Are you getting it from all? Because I didn't find it in Molina, but Meridian I found incentive related pay for performance. I looked in the Molina manual, I didn't see anything.
I think most of the Medicaid HMOs do provide incentive dollars for these.
Okay, I just couldn't find it in the 80-page document.
And these guys did.
Do you know if you're getting any?
Most of them do, but you have to be, like, they don't, on their website, you have to meet with your monthly performance specialist or whatever they call that.
Okay, so there are pay for performance issues or, you know, potential bonuses. So
Yep.
that's nice that we're having that. So this is the HEDIS measures I wanted to show you. And then here are the target compliance percentages just for Meridian. It's just there. It's in your provider manual. You should all be able to get that. Some are available just on their websites and some Jill had shown me. So, I mean, and then the fee schedule, you can go out on your Medicaid and pull down your Michigan fee schedule and look at that and see if there's anything built into there too. But you could probably pull it from your EHR too. Your billers are your good source for all of that information. So this is Molina. This is what I pulled. So Molina says they use the HEDIS, but I didn't have that nice Meridian had that really nice detail. So this is just right out of your provider manual. So I'm not really going to beleaguer this, but you do have it available in the provider manual. They are pulling out information related directly to your diabetic patient care people. It says to go in availability, and that's where those tools are. So you may have to log into your availability account to get that level of detail. And there are a lot of tools in there, which I can't get into your account, but I have seen availability through working with Blue Cross Blue Shield of Illinois. They had that, and there was a lot of stuff in there. Really nice data, graphs, and that sort of thing. So don't forget that's part of the deal. I mean, rural health clinics are not just Medicare, right? All right, so documentation and coding foundations. This is the big one. This little blue guy here, he's your note. He's your medical record, he or she. And whatever's in there, all of the bubbles that go around that medical record really are touching in any way, shape, or form. The first thing I always like to remember is when we have a patient encountering us for healthcare, they're being registered. And I don't like to leave that registration component out of the revenue cycle. That can be an area where you have a high level of turnover, it's a kind of an entry level position. Maybe that person's never worked in healthcare and this is where they're starting. And then they say, well, I'm gonna go to school to be a nurse, or I wanna be a biller, I wanna be a coder. So that purple bubble is very important. Make sure you bring your registration people into your revenue cycle fold. They're part of your team. Everything, not everything, but many of the things that they do as they're monotonously typing and clicking land on your claim. So if you're looking at denials rates and you're seeing a lot of rejections, they're missing plan code numbers, they're making a male instead of female. That's a place where you can really clean up your claims easily by just some extra training, have them slow down, make sure they understand, hey, you're part of the team. What you do goes out on our claim. Bring them into the fold. Don't forget them. Once a patient is registered, I took allergy pills, so I'm gonna grab my water. I've been having allergies, thank you. We're gonna have an encounter note created. So in a clinic, that could be a nurse starting that note, or MA, whoever's rooming the patient. They're gonna make that note. And they're going to, in a perfect world, the provider's gonna do the note, then they're gonna sign it off, and then it's gonna go over for coding. Now, that doesn't always happen. So it would be great if the only thing that lands in the coder's bucket is ready to code. That's not how it always happens. So coders sometimes are deficiency analysts, chasing maybe some signatures when the physicians haven't closed their notes. There's a lot that coders in rural settings have to do that maybe in a bigger hospital. It doesn't happen that way. So I understand that. Coding is also in rural settings, like the last line of defense. The coder is going to read that note. They're going to look for accuracy, make sure they're not saying left all the way down and saying right knee spraining, that clinical documentation improvement. So they're going to check that record and make sure that everything that needs to be there is there before they hit the button. Provider will get credit for the work that they did, and it goes over to billing. When it goes to billing, I like to see it go right out the door. So I want clean registration, perfect documentation, great coding, and then out the door it goes. We want those bills to go, the majority of your bills to go out without a whole lot of touching, because that ugly gold bubble, the denials and appeals bubble, is what takes you the most time and your billers the most time to get your money that you've done the service, you've provided it, and they're saying they're not going to pay you. So you're now fighting for your money in the gold bubble. So the better the blue, the pretty green bubble is, and how smooth your processes go, the more time your people are going to have to work on the portals they have to log into, the phone calls, the back and forth to get your claims paid when you're sending rejections back through or denials. If you get a denial, you can't just push that back through. There's appeals. It's a lot of work. The bubble here, the gold bubble and the dark green bubble, need to be able to work very closely together. So if you're having a biller running into an edit, so I don't know, there's software on two sides. Usually you'll have encoder software the coders work with. It's ENCODER. So TrueCode, TrueBridge is a software, 3M, Optum. It's usually built in your system. So the coder is going to read the documentation, assign the E&M level. There may be some labs, there's some x-rays floating in depending on where you're working. Look for bundling edits. If you can't build these two things together, you need a modifier. So coder is going to do all that work, medical necessity checking. And then it's going to go through. When it hits billing, they have a whole nother set of software usually. It's called clearinghouse or claim scrubber software. It's going to scrub that claim on their end too. They're a nice check and balance. They're there because maybe some of the software built on the encoder side didn't catch a specific claim rule from a specific commercial payer or a specific Medicaid plan or a Medicare Advantage plan that wants this instead of this. So it's a nice tool. So those two work together, and if your biller's running into an edit, they're going to put that claim on hold and work with coding. Coding may have to go back and look at the documentation. So it's a team effort. Okay, so remember that. That red cost reporting, anybody who files claims and gets paid by Medicare has to file a cost report, but we get paid based off our cost report for Medicare. So just remember how important that red bubble is, but all of that is tied to the note. Okay, so that's just what that little infographic goes over. I'm gonna talk about the medical record. So according to CMS, glasses, all medical entry, patient medical record entries must be legible, complete, dated, timed, and authenticated, either in written or electronic form by that person who's responsible for providing or overseeing that service. So legible, time dated, and signed are much easier with electronic charting. We've come a long way from paper charting, but complete is still an issue. So we have to remember that documentation must be completed timely. Okay. CMS also states that providers should submit adequate documentation to ensure that claims are supported as billed, if they're asking for notes, and that each note must stand alone to support the services claimed. So when I code or when I audit or I'm teaching, I always say, I'm ready to send this claim out. Feel free to look at my medical record. And I feel confident. So if I'm a coder, I'm doing my job, I'm putting some modifiers on because I'm telling the rest of the story that this one code doesn't tell, and I think you should pay this for both. Feel free to look at my medical record. That's just how you should think about things as you're sending these bills out. Because medical records are audited and they will look at your medical record. So if you're confident. Incident 2 billing, I just like to put this in. Be aware if you're billing incident 2, that just means you're trying to bill a mid-level practitioner, what they're doing under a doctor's NPI, like they're supervising NPI. And there are things to know about. So if you're doing it in the rural health clinic, it doesn't matter in your all-inclusive rate, just bill it. But if you're billing a commercial payer, Medicare will allow 85% of the fee schedule for like a nurse practitioner or PA, where you can get 100% if it's a physician. So there could be a scenario like maybe, and on the hospital side, it's probably more than the clinic. Person newly diagnosed with diabetes, and the doctor has established the patient is established. They've established their problem. They're diabetic. And there's a plan of care that's established. So the 3 E's: established patient, established problem, established plan of care. If that is continuing and all they're coming in for is weekly glucose monitor, they're checking their logs, they're maybe messing with their insulin, and they're not addressing anything outside of the diabetes, that NPI could go under the nurse and get a full 100% of the Medicare physician fee schedule. All inclusive right at the rural health clinic, so don't even worry about it there. But if that nurse practitioner addresses any acute problem outside of that established problem and plan of care, you just bill it under their NPI. So that's just a quick informational on incident 2. The medical record is the proof you may need to support payment and prevent claims of fraud and abuse. So that's backing up what you're selling, right? That's what you're asking for money. But remember that it's a legal document. So during COVID, my daughter is a cosmetologist and they closed her salon. So she didn't have meaningful work. So she went to work for a local law office with 2 partners. The one that the Reader's Choice Law Office, everybody loves these 2 partners. All she did 40 hours a week was ask for records for work comp and personal injury. 40 hours a week, 2 partners, and she was never caught up. Requesting medical records for a 2-partner law office in a town the size of 9,000 people. So just imagine, okay? So just remember that. And then most importantly to me is it is a continuity of care document. So what this doctor or nurse practitioner does in this room with this patient today provides continuity of care. If another member of the team or an outside we had to refer a specialist, they can pick up where you left off and hit the ground running and take care of that patient. If you're looking at on the hospital side, let's say you have a patient that's maybe in an obs bed or even an inpatient, and all of a sudden they have something bad happen, like an MI or something while they're in your hospital. Everything that's done up to that point where they get into that ambulance and get transported out should be right there for that care team, so they can save their life. I mean, this is a continuity of care thing. So that's, to me, most important, because I don't know about y'all, but I'm a patient. You're a patient. We're all patients here. Bottom line is the patient wins when we do a good job, right? Okay. Signature requirements. I just want to throw a few things on this. CMS does not have a set number of hours after the doctor sees the patient that you need to sign in, okay? But they suggest 24 to 48 hours is reasonable. And there are payers that have this language in their contracts. So it could be a condition of participation in maybe a Blue Cross contract. So be watching that. If you're signing a contract with timely documentation, clauses, you better make sure your person that's doing the coding, that's watching for the unsigned notes, gets on that right away. So if it's a 48-hour clause and you sign it, and it's past 48 hours when the doctor signs their note, in theory, they don't have to pay you. It happens, so be aware of that, okay? There's 2 links inside these slides, and I'm not gonna open them. Palmetto says 24 to 48 hours is reasonable. It would be unreasonable to expect a physician to remember something 2 weeks ago. Do it as soon as you've done your work or as soon as reasonably impracticable. So, and then that other one is an AAPC article, same difference. They're basically referring to the 24 to 48 hour time frame. If it's not documented, it wasn't done, get your notes done timely. That's just a compliance issue. You cannot back sign a note, which in an EHR, you time and date stamp as you're charting. But if you're using paper for any reason, don't ever do a back date, just put late entry, today's date and time, and finish your work. And then there's a link to complying with signature requirements in there as well. So I just try to give you a lot of resources. That's what we're doing here. So CPT, I actually brought my book, but I didn't bring it down here. You don't want to see that book, do you? The CPT and the ICD-10 book weigh exactly 11 pounds in your suitcase. Just want you to know that. All right, when you're looking at the CPT book, just a quick overview. It kind of runs through the way a patient encounters healthcare, and I want to run you through it. But there's the introduction. So I'm a nerd, and when I see the introduction, I read it. Every year I get my book, I read it, because anything in green font in that introduction is new wording. So look at your introduction. And then when a patient comes to the doctor to see anyone for healthcare, they usually have an evaluation and management. Doctor's going to look at them, get the history, figure out why they're here, do an exam maybe, and make some medical decisions, right? Those always started with 9-8 until this year. There are 9-9, excuse me. They now start with some 9-8s. Those 9-8 codes are the telemedicine codes that were built into the book this year. Medicare won't pay for any of them. Just want you to know that. But the other payers will pay for those. So there are a set of codes that are matching the E&M office levels, new or established. And did you use two-way or just audio only? So they're out there. So there is a new 9-8 section at the beginning of the book. You can still be starting with evaluation and management. So let's say I go to the doctor and I have an E&M for a bump on my wrist, and the doctor says, oh, that needs to come off. So the next time I come in for my surgery, luckily, I'm going to have anesthesia, so I don't feel them taking the bump off. So the zeros are the first, after the 9-9s and the 9-8s, first in the numeric order of the CPT. And then during the course of that, there's going to be a surgical procedure. So if you're looking at that CPT code, any number 1 through 6, any of the CPTs that start with number 1, 2, 3, 4, 5, or 6 are surgeries. Even though they don't seem like it, like you'll read the description, it doesn't seem like it's a surgery. It's a surgery. So there are global packages, bundling, just be aware. So something that happened on my wrist is falling in that list. And then maybe they're going to take an x-ray. Maybe they take one before, then they take it off, and they take one after. So the x-ray codes start with the 7. And then maybe they take that little bump and they send it off for a path analysis. So pathology and lab start with an 8. So that kind of helps you move through the book. And then there are, I think this is, yeah, the medicine chapter. That starts with a single number 9. So that's a catch-all chapter. That's vaccines, immunizations, therapy, EKG, spirometry, everything kind of falls into that 9, not 9-9. Then you've got your appendices. Appendix A through Q, there's modifiers. When you get your book, if you're a coder, the first thing you're going to do is go to Appendix B, because that's going to say these are deleted, these are new, and here's the different wording in the ones that were just edited. And then you go to the alphabetic index, which is the very back. So when you're coding, you always go to the alphabetic index in either of the books, find your keyword, go into the book itself, and then you code, because there are a lot of rules and guidelines that you gotta look at before you code. So that's just a quick, now you can all code, right? All right, CPT category 2 codes. They have their own set of modifiers. So CPT category 1, 10 modifiers, like 25. Separately, significant identifiable evaluation and management by this doctor on this patient the same day I did a surgery or a procedure of some sort. 59, pay me for both. So there's modifiers on that side. These are the modifiers, and I'll have a slide. Did it, didn't do it, or excluded. There's composite measures. So these are just the listing of the various codes that are in category 2 CPT, and I'll buzz through some of these. I just want you to have them on here. That's just kind of top to bottom what we're doing. So we probably do a lot of our work. We use the EMR, we're putting blood pressure in. So we put in 120 over 80. That is distinct, discrete data. So by putting 120 over 80, you're showing that you're taking good care of this patient because you check their blood pressure. And in your EHR system, as it's billing things out, it's going to know that this was possibly a diabetic or someone with chronic kidney disease previously on a claim that just got their blood pressure checked. Good job. A lot of this can happen by us charting, just pointing and clicking tobacco use. If we're assessing tobacco use, it's a bonk. We're bonking, we're pointing, we're clicking. That's a technical term, bonk. And that could drop that claim with the appropriate category 2 code. We didn't get to do this a lot before they allowed him on rural health clinic claims. And I don't think our EHRs were developing this much because it could cause our claims to deny. Or here's a question I want you to ask your billers. Is it always happening in your EHR, but you've turned it off in the back end so it won't land on your claims? So I want you to ask that question of your billing. Was this always a feature, but we had it shut off because it was causing our claims to deny? You don't want to turn that back on. Okay, there's supplemental tracking codes. They may have to have a penny if your claims won't go out, like the line item on a claim without a penny. They have nothing to do with direct reimbursement, but we want to get them on there. So supplemental tracking codes, and if you go into your CPT book, which you don't have, you get into page 895 in there and you start looking. This is where I'm pulling this. It's all like it's the introduction for the CPT codes, CPT2 codes. They facilitate data collection. They are optional. Again, there's no direct revenue tied, but most plans are going to follow those HEDIS measures, and those codes are going to drive your HEDIS measures. They all end the letter F. So F is for fantastic. So your codes, your category 2 codes, and then the letter F are fantastic because you're all doing a fantastic job. There are, if you're reading the code in the book, there'll be little superscript numbers. There are 12 evidence-based guidelines that feed these codes. And if you're reading on page 895, you can look at all the 12 agencies that put their 2 cents worth into these codes being out there and indicating good quality of care. You can look and see in page 895, start there at what NCQA or who thought this was important and why CPT put it in the book. There isn't any guidance on how to report it. So in the regular CPT book, code with, use first, don't code with that, each additional minimum of this many minutes. We don't have that because it isn't tied directly to reimbursement. So you have to get a feel for it. But again, I want you to ask your EHR. It's probably built in there. So just know and know your agreements. Know your commercial payers. Maybe you're already dropping these out. I don't know for your commercial payers. But just something I want you to be aware of and I want you to ask. So they are going to just look at what's going on with your patient. So again, a blood pressure measured with a person with diabetes and also some other conditions, pointing and clicking will drop one of these codes, 2000F. We assess their blood pressure and they have diabetes, or any of these 3080F, 3074. It's going to look at the other conditions that are in your ICD-10 code list and assign that. Physical examination of retinal eye exam. So 2022F through 2033F, when the person has diabetes, it's going to push that out, or you can push it out, depending on how you're going to deal with this. Screening for A1C, another set of codes. Kidney evaluation, they're going to look at the EGFR and the urine ACR. And if they are done, they're going to be able to push that out. And then statin therapy. So the statin, those are G codes. Those are HCPCS level 2 codes. Those are not CPT category 2 codes. They're starting with letter G. But they are looking at that as a potential code, and then the adherence is being watched through the pharmacy claims data, which can drop a code as well. So that's all going to have to happen at the payer level, I think, on those codes. Here's your 1P, 2P, 3P, 8P. So 1P, we excluded it due to medical reasons. 2P is for patient reasons. They refused. 3P is system reasons. We didn't do it. 8P is not otherwise specified. This link is this is to that nice little page there. So the AAPC put this out there for free. So if you're just learning, go ahead and check out that link to help your coders or your system build. Then ICD-10 guidelines. So we talked about CPT. that's what did you do to the patient? Then you go to ICD-10, that's diagnosis coding. That's what's wrong with the patient. So be sure you're looking just for diabetic related. Subsection C, section 1, and that's subsection C, chapter 9 talks about uncontrolled versus controlled hypertension. So if we're looking at any of that related to kidney disease, heart disease, or diabetes. And then section 1, subsection C, chapter 4 is the whole entire chapter about diabetes. So I can't sit here and give you all of those codes, but I can tell you where to look to get the guidelines to understand how to report those codes. So this is section 1A, and this just tells you what the heck is this book doing? Why are we using this? What is that funny X? So if I'm looking at these codes, what's that X? That's a placeholder character. But if you've never dealt with this, it's really nice to read the front of the book and understand what's going on. It helps doctors document better when they understand the 1 or 2 more words it would take to get a better, more specific ICD-10 code. So even if the doctor doesn't read the entire front of the book, the coder knowing this and recognizing 1 or 2 more words would have helped me. Is this controlled or uncontrolled? Is the kidney, what's the stage of the chronic kidney disease? Those types of things, 1 or 2 words can help us a lot. So that kind of the conventions, and then there's coding guidelines about, you know, things that are not an integral part of the disease process that's going on with the patient. Is this sequela? So that's just a lot of information there, but it's all in the front of the book, and it's also online. And then section C, the chapter specific coding guidelines specific to what we're talking about today, I pulled out. So chapter 4 is where your diabetes are. Chapter 7 is the eye. Chapter 9 is your hypertension and your circulatory issues. 14 is your chronic kidney disease. And then 21 is factors influencing a health status. So these are like your encounter for screening for diabetes, encounter for screening for lipid or cardiovascular disorders. So these are pretty much, if you're dealing with what we're talking about and the diabetic and all of the potential complications, those are the chapters you would want to really read through and understand. And finally, this slide came from Gary, but I like it. So this is a picture of an ICD-10 manual. I've never seen one. So looking in the keyword diabetes, I know that there is no EHR out there in this world that gives you all of the lists very easily searchable in this window that's about 2 inches by 1 inch, okay? Know that there are scroll downs, keep scrolling. So is it just diabetes, not otherwise specified? That's an E1 1.9. But if this person has peripheral vascular problems or kidney disease from this or anything else, it's really hard to find. So this is just an example of all the things that you could be finding if you dig a little bit. Now it's hard for your providers to find this. So if you're dealing with, this is what you're going to take back and talk to your coders about. What can I do to help you? What can I do to give you more information? If you're dealing with, as you mentioned, a benchmark of how much money you're going to get to take care of your patients from a Medicare Advantage plan or Medicare Advantage, but Medicare shared savings or any value-based contracting, that higher level of specificity is going to say, oh, this patient's sicker than a regular patient with just diabetes, E1 1.9. We need to give this person more money. We need to give this doctor more money to take care of this patient. If you don't give them that, they're going to say, oh, they're just walking around. They don't even, you know, they're diabetic, but so's half the world. They're not going to do anything about it. Your Medicare Advantage plans need that too. That's how they are paid. They're taking some risk. They're working on HCC coding, hierarchical condition category coding. They're going to want that higher level of specificity. So if you're starting to do value-based contracting or working with an ACO, that's very important that we get down to that level of detail so we can tell the patient's story. Our doctor's notes, our physician extender notes are telling the patient's story every time. So we need to get that documented and then we need to get it on the claim. That's where we're telling the story to the payers.
Can I tell you something real quick?
Yes, ma'am.
One time we got dinged on a patient and had a bilateral amputation for the diabetic foot exam.
Wow.
Because we have to say that they lost both of their feet.
So there is a Z code for that. You'd have to put the left and the right.
Yes. But never ran into it before, probably won't again. But I thought
Yes,
it was interesting
yeah.
how
So that's just a quick example. When you're doing those Z codes, left leg amputee status, so left leg below the knee amputee. I can see that when they walk in, the doctor, everybody can see that. But if you don't state it in your note, coder can't put it on the claim, and we can't tell Medicare this person has left leg below the knee amputee status. Medicare knows. So I was a data analyst for our ACO, data analytics person. They would give us a list every quarter. We had probably 40,000 beneficiaries in our ACO. 3,500 of them have a historical HCC that went out on a claim that you haven't billed yet this year. None of your doctors have addressed these. So that was like 10%-ish of our patients. Then they knew darn well, Medicare knew from historical claims data, there was a problem, a chronic condition or something that would drive up your benchmark they're going to give you, but you haven't reported it. And in their eyes, the knee grows back. In their eyes, you're not taking good care of your patients because you're not addressing at least once every calendar year these chronic conditions on a claim with a doctor visit. Guess where you can get them all and count it once a year? Medicare well visits. You don't have to address a single one. You just get them all on the claim because they are going on with the patient. Stick it on that well visit claim. You're going to get your extra money, but also those well visits are awesome. They just check so many boxes. I know you don't like boxes, but what I mean is they do so much for the whole holistic care of your patient doing those well visits, and it's free for your patients. Love it. All right, so looking at quality measures, I'm moving into the HEDIS measures now. There's factual measures, so they're going to say to report what you got, like high, low, whatever. Or there's some that are just going to be checked off because you did a diagnostic or a therapeutic service. So there's a factual and a did we perform. So the first thing we're going to look at is blood pressure control for patients with diabetes. So they're going to assess the percentage of members age 18. Oh my gosh, I can't, the phone call I've been waiting 3 days for. Members 18 to 75 years with diabetes, type 1 or 2, whose blood pressure was adequately controlled during the measurement year. And here's why. I'm not gonna tell you why, but one of those links that I gave you takes you out to the NCQA site, and that's where I'm getting all this information from. And it just backs up to the providers and to your care team why it's important that we check this blood pressure on these patients. Okay. Here's the codes that are associated with it. Nope, because I'm going backwards. Here we go. There they are. All right. These are factual codes. So they're going to go from HEDIS. Again, if you click that, it's going to take you right back out to that NCQA website. So diabetes with hypertension, the CPT category 2 codes are going to be either if the most recent blood pressure was 130, 3074F. If it was less than 80, 3078F. So looking at systolic and diastolic, this is where if you're popping it into the system, it could potentially be dropping these codes all by itself. Awesome. Nobody has to go back in and extract this data. It's all happening. So this is factual data. It's giving just definitive, discrete data. All right, the eye exam for patients with diabetes. So they're assessing the percentage of members age 18 to 75 with type 1 or 2 diabetes who had a retinal eye exam in the measurement year. And again, it's tells you why. I don't have to sit there and tell you clinically why we need a retinal exam. Do I need it? I think you all know why. It attacks the eyes if we're not watching it. So this is just coming from that website. I wanted to have it on here. We want them to be watching that. And then the measures. So this is a did we perform. So there are the CPT codes for the CPT2 that say retinal eye exam, or if you do a 92227, which is the actual act of imaging the retina, and they found one or both eyes they're looking at with remote clinical staff. So this is not a doctor, 99227 and 99228 is with the doctor doing the oversight. If that's going out and that doctor is part of your team, that would potentially check your box with a HEDIS measure. If not, then you're gonna get that note back because you don't have a retinal specialist and they don't have that connection to your billing system. You're going to say we did 2022F dilated retinal eye exam with interpretation with evidence of retinopathy, or 2023F, there was no retinopathy. And as you go down through, you're going to read through that. Or 3072F, there's low risk of retinopathy from the previous year, so maybe we didn't do it this year. Okay, that's telling that patient story, and it's telling how well you're taking care of your patients.
Have you seen any of the iris scans that they're doing in RHCs?
The machine that they have, I have not. Has anybody got an iris scanner? I don't know if they have.
There was a question on how they would capture, we have one too, how they capture it within the all-inclusive rate. Can you get from bill for doing it?
No.
Yeah, it just goes in the cost report. Yep.
So that's why a lot of them don't do that, because you're not
You don't, I've
capturing.
already checked into it, and it's only cost report.
Does it close the gap though?
Yeah, it closes the gap.
Oh, the iris does close the
Yeah.
retinal exam?
Yeah.
Okay, then did everybody hear that? Potentially look at an iris exam machine. If you're in a value-based contract and you need to drive that utilization up, and also if it's checking the patient's eye, that's awesome, right?
But then you, if it is positive, then you refer over.
They have to go, if there's a problem, they send it off to a specialist, I would guess.
I would assume.
I would say. Okay, good feedback, thank you. So anybody, there was a chat, is there somebody that said something and I can see that popped? No, okay, I just thought maybe somebody online had saw it. All right, so now looking at the A1C, same age range, type 1 or 2 diabetes, whose most recent A1C was either less than 8.0 or greater than 8.0. So we're trying to capture controlling this. It's a holistic approach, we know, but this is a measure that, and this tells us why we don't want their sugars running high. It'll wreck every part of their body. And I've got a mother that's totally dealing with it, so I get it. All right, the primary source is for all this information behind this factual measures coming from the HEDIS, and they are CPT2 codes to identify the levels. If you run a hemoglobin A1C, you wouldn't get any opportunity for HEDIS measurement, but if that's something you run and you bill for it, it was a potential revenue opportunity. So if it's less than 7, it's a 3044F. It's greater than 9, it's a 3046. Greater than or equal to 7, but still in the good range, less than 8, 3051F, and then greater than or equal to 8, but not over 9 is a 3052F. So if you don't run it or the lab sort of populates in but doesn't create data, you may have to type this in and somehow manage that. I don't like in your EHR, you may have to have some building in your template to be able to answer that question, or you'll have to have coders abstract the data. So that takes more time. And then looking at the kidney evaluation for kidney patients with diabetes, same age range, right? Yeah. So again, they're looking at the estimated GFR and then also the urine ACR during that measurement year. So they're looking for blood and urine to see if there's any damage to the kidney. There's the why it matters. Like I need to read that to you intelligent people. And this one is still coming from the HEDIS measure. So CPT2 codes would be positive microalbumin, I can't say that, that was documented and reviewed. So we saw it, we reviewed it, 3060F. A negative microalbuminuria test, 3061F, or a positive macro test that was documented and reviewed as 3062F. So if you're building a template to capture these automatically, the doctor could have those buttons to push that would drop that code automatically as discrete data. Otherwise, the coder's going to have to abstract it. That's what I'm trying to say. Any of these things, you're just starting to think about it because maybe you haven't been sending these out, that you could build into your template in your EHR and make it more smoothly processing and stop that back end data abstraction is better. I mean, that's just, so if you've got a spot and it's a diabetic patient note, and those are in there now that the doctor reviewed it, he or she could click that button and it would drop that code on it. Until we're taking really good patient care or care of our patient. And that was, that was a did we perform it. And then finally, statin therapy for patients with diabetes. So what they're looking at here is 2 parts of this. They can't have atherosclerotic cardiovascular disease. So those people are out. But if it's 40 to 75 is your age range, they have 2 things. They have received statin therapy. So they were prescribed at least 1 statin medication of any intensity. And then there's adherence. So they have to have 80% intensity of at least however long they're looking at a year. They have to have showed that they at least fill their prescription 80% of the time. And there's a lot of why it matters there too. You're all very smart clinical people, so I don't need to read that to you. So we're looking at HCPCS2 codes. The patients who are, it's not a category 2, it's a HCPCS2. Patients who are currently on statin therapies and received a prescription could be a G9664, and this could go out by itself as well. Patients who are not on a statin and they did not receive an order. Documentation of a medical reason for not currently being on a statin for lots of good reasons would be a G9781. And ordering and doing a lipid panel, an 80061 would would be a way to get revenue. I don't know that that would necessarily, get you any HEDIS measures, but you would get revenue ordering the pills, okay? Other codes just to look at related to diabetes, advanced care planning during your, not even necessarily related to diabetes, but when you're doing your well visit, if you do advanced care planning inside the well visit, which is the 99497 for the first 30 minutes, and then beyond that, 99498, you can get extra money at your facility and not charge the patient anything. So that's, you know, advanced directives, that type of thing. Yes.
How much time has to be spent just on ECP for that? Is it
Um,
16 minutes?
30 minutes,
Oh, is it full 30 to know that?
30 to get the
In
99497
addition to the AWB time?
in addition.
That's a long visit.
It is a long visit. So if that's the only time it's waived, you can do it any other time, but there'll be co-insurance from the patient. This is if you do it in conjunction with an annual well visit, yeah, 30 minutes. Sorry, but that's
We'll flag them, like if they know, if they're interested in it or market, and then we'll have another conversation. I would keep them out of the room and stuff like this. Because sometimes those do take a lot longer.
yeah. So the provider would have to document that 30 minutes.
Yeah, provide.
Beyond, you know, there's no time limit on the well visit, but I hear what you're saying.
Right.
Yes. But the cost sharing is waived, so I just wanted you to know that. And also, I don't know if I have it down here. Yeah, I do. How about collection and interpretation of physiological data? We talked about CGM. So if you're doing CGM data analysis, the doctor is checking it over, doing training, regulating their insulin, minimum of 30 minutes each month. That's a 99091. So, and the report, that's falling kind of in the remote patient monitoring, which we are allowed to bill. I think I have it on the next slide. All right, HCPCS 2 codes, doing an SDOH screen, G0136. So that is a billable service by the doctor. It's reimbursed at probably $12 for Medicaid and maybe $18 for Medicare. Not a lot of money, but there's co-insurance unless you do it during an annual well visit. And the caveat to billing this G0136 is you need a trigger. It has to be a yes answer, something that triggers the provider to have to be aware that there's a barrier to some sort of the treatment plan. Okay, so if you're running this, you don't want to just bill it every 6 months for a free screening. It has to have some sort of actionable item that the physician or the care team, doesn't necessarily even have to be the physician, like it triggers the clinical social worker, it triggers the caseworker, the community health worker. So usually the wording in Medicare is a yes answer. So if you're asking 10 questions and you got a yes there, are you in danger of being homeless? Do you have not enough money for food? That would be where you would bill that G0136. If you're doing it during a well visit, no cost sharing from the patient, free. You'll get paid for it. Otherwise, it's cost sharing, but not like $1 or $2, but still, it all adds up. Diabetes outpatient self-management training services, G0108 or G0109. You can include the cost of this in your cost report, but you don't get any extra separate payment, but it is out there. And then the G0245, initial physician E&M of a diabetic patient with diabetic sensory neuropathy that has a loss of protective sensation, the LOPS. So it's got pieces of that. That would be a G0245. There's someone asking me a question? No. Okay. Movie, was there a question?
My computer.
All right. Care coordination services, we got all that. If you click on this link, you'll pull that open and all of the codes will be there for you. I promise I won't pull them up. So they're allowing these. We mentioned that you can use the G0511 till January 1st or till July 1st. But this is the nice little MLN that you can find all that information about. Wanted to share that. And some more little MLNs. I'm an MLN girl. The first one is just an RHC informational, and you probably have seen it, but if you don't, keep that bookmarked in your browser tab because as it updates, there's a lot of good information in there. So tons of billing information, things about telehealth that may have changed. This probably will, I haven't seen it get updated, but because they just started allowing level 2 category codes, category 2 codes, I imagine they're going to update that fairly quickly. It hasn't updated yet, but it will. And whenever you're looking at any of these, the red font, take your eyes to the red font. That's the new stuff, okay? The middle one is HHS, but it's telehealth and remote patient monitoring information, because you mentioned you wanted to bring that up. And then billing under a rural health clinic as a safety net provider. There's your rules, your most current rules for any telehealth related services from your rural health clinic. And then you probably already knew this because it was it's July 1st. Payment for Medicare Part B preventive vaccines and administration in RHC. Instead of waiting to recoup it on your cost report, there's the information about that. And this is a really cool website. This is the preventive services website. So as you start looking through this, it just sort of glows and moves. That's the link. Anything with the T is allowed to be billed via telehealth. Remember, if you're being telehealthing in a rural health clinic to Medicare, it is not really great. It's what, $92. But you can do it not telehealth. So anything there talks about coverage. It does give you a link to the health insurance, the HETS that we mentioned back there to see when the last time they had any kind of a visit, your frequencies. So it's kind of like a really nice little tool. So this is a page as a preventive services provider office. They should be bookmarked, I think, in your browser, because you can look at all these services when you're putting together their well visit, their preventive plan, or anything that might be popping up for that patient, like your lipid panels, everything is on there. I don't know if you can see that on the screen. It's kind of small, but that is a really great page. So that is that. Where we at? Are we at 4 o'clock? I was the anchor. I had to come pretty fast. Thanks. I know that wasn't really exciting, but you can take your time with the slides and look at all the links, and it's just a ton of information. Research.
Any questions for Jackie?
Question just in general for those that show the 9896667680. You only bill those to Blue Cross commercial, or are you billing them with the
Make them
But any other commercial insurance?
We don't have a lot of managed Aetna. I have some state health cover it.
So you get a retention on those?
Either a rejection or it'll cover like $2 software patient. And then the patient is still responsible for like the $20.
Yeah.
So.
I wanted to share with everybody that my post in advanced care planning has been a topic that has come up more than once in our conversations at MCRH regarding our palliative care work. So I just wanted to let you all know that this webinar is coming up on May 22nd, specific to rural healthcare professionals, talking about my post in advanced care planning, free to attend. So it's on our website, and I'll put a link in the chat. And I'm here out in person if any of you guys have any questions.
Any other questions for Jackie?
I have cards and my information's in the slides. If something hits you later, just shoot me an email. And if I don't know, we have a great pool of resources that can help you.
So again, we will have the May billing and coding boot camp. John Burns will be here. Again, it's $50. It's valued at, I think, $4.99.
$500.
Yeah, and really the $50 is solely just to cover the food costs because we can't use dollars, our flex dollars and our core dollars to cover food. So the $50 is, your beverages, your lunch, that kind of stuff. If you have people within your clinics or your accounting departments, please send them. And then additionally this year, which is new that we've not offered before, is the critical access hospital. So specific to your hospital billing and coding, which Jackie will be here. But then additionally, the second day, we are going to offer a provider component. And so I'm hoping that we can get some providers in the room. I mean, it's one of those things that, again, there will be CEs for the providers. But from the provider's perspective, and Jack, you can probably speak more to this, it's just so important to give them the education that helps down the line.
So John Burns and myself will be doing it, just kind of talking about maybe trends that we see or ideas to help clinical documentation improvement. Because again, if it's not written down, you can't get the reimbursement for it, and we can't tell the patient story. So it's really going right to the person who's writing the medical record and helping with that.
So that'll be in August. That information will be coming out soon. Any other questions or any burning topics? I know we had planned for a little bit of Q&A time, but is there anything left? I mean, I love the presenters myself today, so a big round of applause for our presenters. I appreciate their time and talent to come in and give you all that information. So with that, if there's no other questions, I do want to ask again, it's important for us to have feedback and information. Aaliyah is putting a link in the chat. And also we'll send an email to everyone to complete the eval for us. One, give us ideas of things that are important to you that you really want to have topical information on. Two, give us the feedback so we have the data to prove our value here in the state of Michigan, but also across our nation with regards to state offices of rural health and the flex dollars and the resources that we bring to all of you. So awesome. Thank you everyone for being here. We really appreciate it. It was great having you in person.
I was alive, but all right, long time.